Sonu, good evening.
Good evening, everybody.
We are live.
Good evening, good evening, good evening to this evening of talent. And it's an evening that all of us have been waiting for 1 week later after the talent show from the East. We move on to the Central, and today it's the Central Zone's turn to show the talent Central has. And believe me, we have bright young faces all for you waiting to show their talent. So let's be with us, with everybody, and the talent that we are going to see is something that's going to amaze all of us. So I begin an introduction of our chairpersons and our judges who are going to be here for the next 2 hours. Thanks, as usual, to my very, very supportive governing council, who are the spine, who are the backbone behind all our meetings. The Team Scientific Committee, AIOS, members who work so hard, Dr. Amit Porwal, Dr. Feroz, Dr. Jatinder Singh Bhalla, Dr. Krishna Prasad Kurlu, Dr. Parikshit Gokte, Dr. Som Shilamurthy, and Dr. Sonu Goel. Thanks to this wonderful team, and it is for them that we have all our programs week after week. It's my great pleasure to welcome Chairperson Dr. Mahipal Sachdev, sir, President AIOS, Chairman Scientific Committee, IRSI, Chairman and Managing Director, Center for Sight Group of Hospitals. Welcome, sir. Welcome, Dr. Lalit Verma, sir, Vice President AIOS, Director, Retina Services, Center for Sight, New Delhi. Welcome, Professor Namrata Sharma, our Secretary, AIOS, Professor of Ophthalmology, Cataract, Cornea, and Refractive Services, AIMS, Delhi. The moderators for this evening are Dr. Feroz and Dr. Parikshit, who are going to take us through this wonderful talent of the Central Zone. It's a great privilege to introduce to you our judges for this evening, Professor T.P. Lahane, Director, Medical Education and Research, State of Maharashtra, India. Dr. Jyotirmoy Biswas, sir, good evening and congratulations, and thank you very much for being with us, Director of Uveitis and Ocular Pathology Department, Shankara Netralaya, Chennai. Thank you, Dr. Natarajan, sir, for joining us as a judge, immediate past President AIOS, Chairperson and MD, Aditya Jyot Eye Hospitals. Thank you very much, Dr. Ajit Babu Maji, Medical Director, Center for Sight, Hyderabad, and also a past President of AIOS. Dr. Lakshmi Mahesh, a dear friend, Senior Consultant at Manipal Hospital, Bangalore, visiting oculoplasty surgeon, consultant at Netradhama Super Speciality Eye Hospital in Bangalore. Dr. Dhami, sir, Senior Consultant, Dhami Eye Hospital, Ludhiana, Punjab. Dr. Mayuri Kamar, Consultant at Eye Care Research Center, Ahmedabad. Dr. Anand Parsarthi, Medical Director and Chief Surgeon of Center of Vision Eye Surgery, Chennai. And with that, a very, very warm welcome to all our viewers and all our vibrant speakers for this evening. And I would request Dr. Mahipal, sir, and then Dr. Lalit Verma and Dr. Namrata to welcome all our viewers, the judges, and our participants tonight. Mahipal, sir.
Thank you, Dr. Partha. Yeah, always a pleasure. And I think this is the next episode from the Central Zone. And we look forward to new innovations, new inventions by the youngsters. And as I've been saying in all the previous episodes, It's really a treat to watch the brain power and the ophthalmology power that the youngsters are bringing on the table. So I think I'll wish everyone who is participating in this particular session to give in their best, and we look forward to a scintillating session and great enrichment of our present knowledge in ophthalmology. And I'm sure the next decade belongs to India in the world ophthalmology scene. So without much ado, let's have the youngsters present their innovations and new inventions that they're going to talk about from the Central Zone. And keep up the good work, members of the scientific committee headed by Dr. Partha, because I think it's an excellent morale booster. It's a shot in the arm of the youngsters that they are being given this platform, and they are being awarded. And those who actually don't even get the awards, they get the impetus to do better and to do more. So kudos to scientific committee, kudos to Partha, and all the very best to all the participants. Thank you.
Thank you, sir. Dr. Lalit Verma, sir.
You see, it's nearly 1 month that this scientific committee started this great learning experience. I would say learning because all of us here also learn from these young Turks, as Amit Porwal keeps calling them young Turks. And through this great innovating session, which I must say, the brainchild of Dr. Partho and the scientific committee, and believe me, one of the best projects of the scientific committee till date. You see, to the extent that this already is making waves. In fact, at Center for Psych today, sir वो आज talent hunt है. मैंने कहा हाँ पक्का है. So that is the waves Partho and Amit and all the members scientific committee people have created. And also, you see, you just heard our president Mahipal, and all the office bearers are stunned to see so much of talent. And even, you see, last couple of episodes, Dr. Mahipal also said that this AIOS Office Bearers Committee or GC would be willing to help all these upcoming youngsters, whether they require some help in filing patent or some other kind of help in research. So AIOS will not be found wanting in such things. And today, this is due special importance. We have Padma Shri Professor Lahane with us as a judge, and whole lot of talented people, which include Jyotir Biswas, Natarajan, Ajit Babu Majji, and so many other judges who are there to help us to get the best out of the Central Zone. So all the best to all the contestants, and I'm sure that all of them will do a great job. Best of luck to everybody.
Thank you, sir. Thank you very much. Professor Namrata.
Thank you, Partha, for organizing yet another talent show. And we've moved from the southeast. Today it is the Central Zone's turn, and I'm sure when you're there at the platform presenting, I think that itself is a big thing. And it doesn't matter who gets the final award. It is all about presenting. It is all about starting, and at your level, it is about getting a platform. I think the best part about this is that it not only has videos, but it has cases as well. And very soon, I think Dr. Mahipal has also said this, and Dr. Lalit Verma has also said this, that we are going to help everybody to patent things, to copyright things. We are already in communication with the officials regarding the same. And very soon, that solution will also come out, because I think it is our duty to help our members to reach that level. So thank you, Partha. And I think we should begin the talent show with all the judges, esteemed judges, as well as all the young ophthalmologists who are there with their cases and videos.
Thank you very much, Dr. Namrata. And everything is possible. Nothing is impossible. And that's what the young minds are going to tell us. And I have to thank Intas Pharmaceuticals for helping us, for sponsoring these events week after week. And even the final sponsors are going to be Intas. So thank you very much, Intas. So now the next part of the program is going to be carried on by Dr. Feroz and Dr. Parikshit. So over to you, Feroz and Parikshit.
Thank you, Dr. Partha. And once again, hearty welcome to everyone, the esteemed judges, the office bearers, the president, secretary, the vice president, everyone over here. And we are looking forward to a great show. So without much delay, let us see what these talents have to present to us today. So as our first speaker of the day, we have Dr. Gunjan Saluja. So may I invite my colleague and great friend, Dr. Jatinder Balla, to introduce Dr. Gunjan Saluja before we go into the presentation.
Thank you. I think it's a great honor and privilege to invite the first speaker of the day of this beautiful program of talent search of the Central Zone. Dr. Gunjan Saluja, she did her MD from RP Center AIMS and also then did DNB and fellowship in International Council of Ophthalmology and FICO in Pediatric Ophthalmology and Strabismus. She did her senior residency in squint and neuroophthalm and oculoplasty from RP Center AIMS. She has numerous publications in peer-reviewed national and international journals. So all yours, stage is all yours, Dr. Gunjan. Please start your presentation.
Balla, Dr. Balla, just before this, Dr. Natarajan, who is a judge, has not yet been able to log in. We'll just wait for 20 seconds. We are calling him up. If sir is not able to log in, then then we will carry on. But if we'll just wait for 10 seconds, I think.
Absolutely.
Okay.
Absolutely. It's actually a moment of pride that we have so many good talents in India, and all these presenters today, I have seen them, and I'm sure all of us as scientific members, we have seen these faces in various forums, in different sessions in All India Ophthalmological Society, the Young Ophthalmological Society of India, and each and every one of them who's representing their state and the zone is equally good today. So it's an honor for us also as a scientific committee to have you all here, young talents, with your excellent work. And let's see how it's going to be. So we have Dr. Gunjan ready with her presentation. Gunjan?
Yes, ma'am, I'm ready.
Perfect. So your video is not on.
Okay, fine. I think carry on. Dr. Natarajan will take a while to come in. So let us start off with our presentation.
Yeah. So I think we can defer marking for this presentation. It doesn't matter. You can take the average of the other judges.
Yes, that's what we do. Yes.
Okay. So good evening, everyone. I'll be discussing about the various wet lab training models which we had designed for residents during their COVID-19 era. So surgical training, as we know, is of utmost importance of training of the budding ophthalmologist. But we know with the rampant of COVID-19 cases, the routine surgical cases have come to a halt. And this has affected the resident surgical training the most. So what do we do next? We can practice a large number of surgeries on the animal eye model. And this was our aim. And we also tried to develop a new model, that is a do-it-yourself model, to practice the basic cataract surgery steps. So goat's eye, we all know, are conventionally used for practicing cataract surgeries. These are easily available and inexpensive, and they can be obtained from the local slaughter houses. When mounted on the mannequin head, they can be used to practice these surgeries. So which all surgeries did we practice? We practiced corneal scleral perforation repair, trabeculectomy, and strabismus surgeries using the goat's eye. So for corneoscleral perforation, first an artificial corneoscleral perforation was incited in the goat's eye, and then the repair was done using the vicryl and nylon sutures. Similarly, recession resection surgeries and plication surgeries for squint can also be practiced in goat's eye, which have already attached extraocular muscles, as is visible in this picture. Buckling surgery can also be practiced. This will help the surgeons to actually to have a feel of passing the scleral sutures during the buckling surgery, and also to pass the band. Similarly, trabeculectomy with releasable sutures can also be practiced in the goat's eye, giving the confidence to raise the scleral flap and conjunctival dissection without causing any buttonholing. A do-it-yourself model was tried by us. See, we know that various artificial eyes like phaco eye and Kitaro eye sets are commercially available,
यहाँ
but these
पर
are
उसका
for
पैजामे है क्या मम्मी?
but these are only for single use and they are not cost effective. Hence, we decided to use a cost effective multiple use models. So, and we used a rubber ball in which the crater was created. It was approximately the diameter of the cornea which we were about to use. And the lens was made by combination of cornstarch, water, and glue, which were heated for 2 minutes. Cornea can be used either by using already used phaco eye if there is available in the wet lab, or it can also be used by cutting the nipple of a milk bottle as is shown in the video. Then the lens is placed in the crater over which the cornea is fixed with the help of Fevikwik or a Fevi glue. This cornea can be fixed, and various steps of cataract surgery like creating a trench, chopping, can be performed in this model. Intraocular lens implantation can also be practiced in this model, as will be shown in the video. After this, the residents were provided with a questionnaire at the end of the practice session. We just, as it was just a practice model, we tried it only on 5 residents, and it was found that they did gain confidence in performing the surgery, and also it gave a good experience for sculpting and chopping. So wet lab models are simple and cost-effective way for training the residents. They help to gain the confidence. DIY model gives a realistic experience in performing steps of cataract surgery, but a long-term in a larger sample size studies, questionnaire-based studies are required before we can implement them in the usual routine training. Thank you.
Excellent presentation, Dr. Gunjan. Now, may I request our lead judges, Dr. Kamar and Dr. Lakshmi Mahesh, to have a discussion on the topic. Over to you, Dr. Kamar.
Gunjan, excellent presentation. Congratulations on that. What I want to know is you have put a lens, but there is a crater behind, which is a hard thing.
Yes.
So it is only the putting up your probe into that material. The actual feeling of the chamber, which is and fluttering of the iris and all those things, or even nucleus drop, all those things is missed in this model. So there is the back part of the lens is not that like eye, it's a hard thing. So that is one thing I noticed. So that may not give you the actual feeling of phacory.
True, ma'am.
But it is useful for the hand-eye coordination. So that way it is good.
Gunjan, I have 2 questions for you. First of all, let me say that you presented very well. Excellent. And what was the analogy of bringing in the bullseye or the oxocyte into this? Like what you just wanted to, because a major part of the presentation was that. Point number 1. Point 2 is, who were the residents who tried out this? What about all the residents across the country? Do you have a game plan for them to emulate the same thing, to set up the same thing in their respective institutions?
Yes, ma'am. See, the wet lab models, either we can have animal eye models, which can be easily available for most of them. But there were some days where even animal eyes are also not available. And most importantly, in the goat's eye, when we are practicing the cataract surgery, the goat's eye nucleus is very soft. And sometimes we do not get to chop them or sculpt them or practice sculpting on them. So we decided that we can make an artificial lens, which we can even later on implant in the goat's eye, and we can do phaco. And at the same time, we can, even if the goat's eye is not available, we can use from the locally available materials also can be used by anyone who is even in the remote areas.
Hard enough? Was this hard enough? Because
yes,
Dr.
ma'am.
Mayuri said that the both sides very soft. So was this hard enough for you?
Yes, ma'am, because the
Okay.
cornstarch, as you increase the concentration of cornstarch in water, definitely it is going to increase the hardness of the material, of the nuclear material which is being created.
Okay. And who were these residents who tried it out and
Yes.
evaluated the score?
Yes, ma'am. So we included 2 senior residents and 3 junior residents who are actually being trained in phacoemulsification. That was second year residents and 1 third year resident, final year resident.
I think
And so you have an answer for all the residents across the country, because that will be the USP of this paper.
the junior most should be given the trial. And
No,
we
are you
should
having
continue
a kind
giving.
of a model to create for all of them, that ball and where they'll procure it and things like that?
Yes, ma'am. Sure, we can have that model.
Congratulations. Thank you.
Thank you very much,
So,
Dr.
so Feroz, if I can just pitch
Yes.
in, we have at RP Center state-of-the-art National Surgical Skill Development Center for ophthalmic surgeries, and we get goat size routinely and also synthetic eyes. The only thing is that during the COVID times, even the supply of goat size had stopped. So this was an indigenous thing, that they thought of, and they thought of many other. All over India, residents are there, and surgical skill training is something that has taken a setback during the COVID times.
Thank you, ma'am.
But
Any of the judges can ask question. Dr. Ajit Babu Majji.
Yeah, you said your main this thing is COVID era. How it's preventing COVID era complications in your model?
So it's the model is in the goat side we can practice a lot many surgeries other than cataract
All
surgery. That was
animals
one.
are free of COVID as far as of knowledge is concerned.
And formalin is also these are also being dipped in the formalin, so we can, and we were wearing all the gloves and other things, so we can have that. And secondly, the indigenous model which we tried to create was also helpful.
All right. Dr. Lahane.
Another question is,
Yes.
if I see the consistency, it appears to be very, very soft. Actually, Lakshmi was pointing out that how do you, at least you could have demonstrated to us that one very soft nucleus and one hard nucleus, so that the consistency, you can say, you can make it more precise in your phaco fragmentation.
Okay, so if we have added less amount of the entire consistency of the nucleus will depend upon the amount of cornstarch when we are making the nucleus. So if we are increasing the quantity of cornstarch and water, definitely the nucleus will be harder. That is what we had shown in the phacoemulsification also. Well, in the video also, sir.
Video, it appears very soft.
But actually, it wasn't. It was
okay.
not.
Right.
Right. Thank you so much clarifying, Dr. Gunjan. Dr.
Thank
Lahani, do you have any question for Dr. Gunjan?
Her presentation was very good, and all the questions are asked. Only one question I will ask: that how you avoided the COVID? Because see, the goat's eye, they can carry the COVID virus. So how you have avoided that COVID virus whenever you are operating? What precaution you took?
So first, as I told that we can use the goat's eye have been dipped in formalin. Formaldehyde itself is believed to be one of the disinfectant. And secondly, we were all using gloves while handling these goat's eyes, and all the universal precautions were we were taking all precautions so that we do not get COVID. And most importantly, during the peak time of March and April, and even in May, mid-May, we were also not getting goat's eye for the wet lab. So it has just started a month back that we have started getting goat's eye.
Okay. Congratulations. Thank you.
Thank you.
Thank you very much. We can have one last question from any of the judge, if at all there is one.
Have you tried it with the different phaco machines?
Ma'am, in our wet lab, we have only Infinity machine set, Alcon Infinity machine set up. So we have just tried it on that only now.
That also helps you in.
All right.
It was a good idea.
Yeah, excellent. Thank you very much. And thanks for an interactive discussion on the same topic. Dr. Parikshit is here. And Dr. Parikshit, do you want to go ahead? You're muted.
One is what Dr. Saluja has tried. We are also trying that in a large way in Maharashtra using wet labs, but that's another day's story. Now, I would like to invite Dr. Jyoti Shakarwal from Rajasthan. She's speaking on illuminated microcatheter assisted circumferential trabeculectomy, IMCT, for congenital glaucoma. Now, that sounds very, very specialized. And as judges, we have Dr. Mayuri Khamar and Dr. Gobind Singh Dhami. I would request my friend, Dr. Amit Porwal, perhaps the most active of us scientific committee members, to please introduce Dr. Jyoti.
Amit, Dr. Amit, you're not audible. In the meanwhile, Jyoti, you can start sharing your screen.
Audible or no?
Yeah, now we can hear you.
Yeah. So it's my pleasure to introduce Dr. Jyoti. Dr. Jyoti did her undergraduate from Jaipur and her post-graduation from RP Center AIMS. To her CV, she has been awarded with numerous medals. The list, which I can't name all. She's got various index publications. She's got various presentations in national and international forums. So basically, she's an academic.
Amit, not too audible, Dr. Amit.
Am I audible now?
Now better. Do you want to just...
Now better?
Yes,
yeah.
much better.
So, Dr. Jyoti is basically, she did her undergraduate from Jaipur and her post-graduation from RP Center AIMS. Her CV is very elaborate, but just to mention in short, she is an academician at par excellence. She's been awarded with numerous medals. She's got various index publications. She has presented her scientific material and work at various national and international forums. So over to you, Dr. Jyoti, and all the best.
Thank you, sir. Good evening, everyone. Am I audible?
Yes, and visible.
Okay. Thank you, AIOC, for giving me this opportunity. So I'll be talking on comparison of illuminated microcatheter assisted circumferential trabeculotomy with ab-externo trabeculotomy in primary congenital glaucoma. The ultimate treatment for congenital glaucoma is always surgical. We have goniotomy and trabeculotomy under angle surgeries and trabeculectomy as a filtration surgery. So here we are discussing trabeculotomy by using Harm's trabeculotome with illuminated microcatheter assisted circumferential trabeculotomy. So this catheter is a fiber optic based device with a flexibility for 360-degree catheterization, having a diameter of 150 microns with an LED light source for transcranial visualization and an atraumatic tip. This is a surgical video showing the procedure. After opening up the Schweim's canal and injecting viscoelastic, the catheter is gently inserted into the Schweim's canal. It was passed throughout the canal entire 360-degree by the help of transcranial visualization of the tip, and 360-degree catheterization is completed. And the both ends of the catheter are gently pulled to incise the entire 360-degree canal. Flap is closed further. Coming to the results, the baseline characteristics were comparable in the two groups. The chief presenting complaint was the corneal opacification and photophobia, followed by buphthalmos and excessive tearing. Complete catheterization was achieved in 16 eyes out of the 20 in the catheter group, and at 1 year, the absolute success was approximately 87% in the catheter group, which is significantly higher than the ab-externo trabeculotomy group, which was 60%. There was a significant reduction in IOP in both the groups at each follow-up, with a significant difference between the two groups at 6 months and 12 months. No significant difference was seen in corneal diameter in either of the group. Corneal clarity showed a significant improvement in both the groups. Microcatheter obstruction was found in 4 eyes in the illuminated microcatheter group, and hyphema was seen in 18 eyes in the catheter group, which resolved spontaneously. None of the eyes underwent surgical procedure for the hyphema drainage, and similarly, transient hyphema was found in 7 eyes in the abexterno trabeculotomy group. There was a significant difference in this. And coming to the resurgery, 1 eye needed resurgery in the microcatheter group, which was significantly higher than the abexterno trabeculotomy group, in which 4 eyes required resurgery. The limitations we have in the study, of course, the high cost of the procedure itself is a big limitation. There is a steep learning curve of the technique and lack of long-term follow-up. Soon we are going to reveal our 4 years result of this technique. So to conclude, the IMCT causes a greater degree of reduction in intraocular pressure and may be preferable as a primary procedure, especially in children presenting at a younger age. Thank you.
Thank you, Doctor. That was very succinct and in time. So I would request the 2 judges, Dr. Mayuri Khamar.
Jyoti, again a very nice presentation.
Thank you.
I would like to know what is new that you are showing to us, because I have seen many presentations and the papers published for this technique. Availability of this catheter in India is an issue. It is very expensive, that you have already said, and the learning curve is very high. Even finding the SLAMS canal may not be possible in all the cases. Particularly, you have included age group up to 2 years. So many a times in the older children, there is atrophy of the SLAMS canal, atresia. One more thing I would like to know, when we are doing the 360-degree trabeculotomy, you are pulling out the catheter. What happens post-operatively over a period of time? There will be a membrane formation in the angle structures. So the whole purpose may not be served by treating the 360-degree. I'm not against the technique, yes, but something may be needed. Long-term follow-up is must in all these children, because even trap group is not that bad compared to this. The significance was not very high.
Ma'am, we have done this study for the first time in the Indian eyes, and we compared this technique with the trabeculotomy. Definitely, we have taken less than 2 years, because more than 2 years, as you said, this we are not able to find. So that's why we included less than 2 years. The more earlier the presentation, the more severe the glaucoma, the pediatric glaucoma is. So less than 2 years age group was done. And apart from that, ma'am, in the as we are doing trabeculotomy also as a initial procedure in few eyes, reserving the trab filtration surgeries may be needed further for the second surgery, as it has the mitomycin C and all these related complications. So instead of catheterizing the 120-degree with the trabeculotomy, we can do the entire 360-degree, which may give us the long-lasting, more better than this incising 120-degree with the metal trabeculotome. Definitely, we are going to review the long-term result also. We have few studies which are retrospective. 2-3 studies are retrospective, and with a fewer number of eyes. One, the Serkiston and Gherkin, they have 16 eyes in their study, and we are doing more eyes also with a long-term follow-up, definitely.
Was it a randomized selection or?
Yes, ma'am. Yes, ma'am. It is a randomization. The previously published are not randomized with the retrospective studies.
Yeah, Jyoti, in your summary, you have said it is a first-time study, but we are listening this talk for several, maybe 3 years, 4 years also. The same study.
Thus, there are 2 years. The longest follow-up is 2-year follow-up by Celia et al. And recently, there is one 2-year follow-up also came out. The Celia was 4 years back, and this one is 1.5 years back. 2-year follow-up is the maximum follow-up.
Your study is not the first study.
In Indian eyes, sir.
Indian eyes?
Yes, sir, in Indian eyes.
Dr. G.S. Dhani, sir.
Yeah. No problem, no problem.
Jyoti, on the onset.
The other thing I want to ask is, you said hyphema.
Yes, sir.
Are you quantifying the hyphema? And what are the long-term effects of hyphema over the functionality of the procedure?
Sir, we look for the transient, complete hyphema was there in the one eye, total like more, and others are remaining 15 eyes are having transient hyphemas. We did not quantify in means particularly with the or amount measurement because they are kids basically, so we can't measure, but the total or transient it was seen.
Yeah, Jyoti, it's a good presentation.
Thank you.
New technique, but I wish you had started with the identification of the structures. Identification of Schlem's canal is such a difficult thing, and in your videos, I could not get it. Second, much simpler techniques like viscocanaliculostomy with Helon was tried so simply, and I wish you had started your videos more with identification of the structures, identification of the angle, complication the angle, and where you would have been lost. It's a good technique, very expensive, and comparing it with other simpler techniques, I would restrict my views to others than jumping out to your first time presented technique. I wish you simplify the whole procedure for a common user. Well done.
Due to lack of time, I just shorten up my video with the insertion and this thing.
Dr. Jyoti, are you practicing this procedure in Jaipur?
Yes, sir. No, not in Jaipur. I have just finished my senior residency.
So this is being done in RP Center.
RP Center, yeah.
Is this fiber optic cable freely available in our country?
No.
The samples were available there, so they are definitely free of cost for this purpose. But
thank you.
Is it a disposable prop or you have to change it every time?
Sorry, ma'am?
Micro catheter.
Yes.
Is it reusable?
Yes, ma'am, it is reusable.
And what's the cost?
In 4 or 5 eyes, ma'am, we can use, ma'am, approximately 90,000 for one. Yeah.
In your video, it's a highly magnified video. So yes. All 360 degrees of passing of the catheter is not visible. Of course, Professor Dame has pointed out that you have not shown this Schlem's canal. At the beginning, you should have shown the Schlem's canal. After that, all 360 degree passing of the catheter is also equally important. Of course, towards the end, you can see the illumination of the catheter.
It was microscope, sir. It was focused.
Microscope is in your hand and magnification is also in your hand.
No, when we present that technique, identification, the first step is very important. Because if you misdirect it, then whole point is gone.
And the desmet and other problems could be there if it is misdirected.
Yes, ma'am. 4 eyes had
It is right. It is not the technique to be taken so easily. Take some time.
What complications you had when the misdirection occurred?
Sir, misdirection, it was not forward, it was not proceeded further. So squirrel cut down was done at that site only, and the tip was taken outside, and whatever we can incised, whatever degrees, and the other side was done with the Harm's trabeculotomy. We did, we identified the Schlem's canal. After making the flap, we incised the thing and look for the oozing up of the aqueous. So that's how we, for the identification of Schlem's canal.
Landmark actually.
Sure. Thank you, Jyoti. I think I will hand over to Dr. Fairuz to start with the third participant.
Fairuz, if I can just have 10 seconds. I would request all the judges to do the marking on the Google Sheet, and it's an online marking. If anyone faces any problem about the Google Sheet marking, I've just put the name and the telephone number of Mr. Sai Krishnan in the group. You can contact him immediately and he'll help you.
We are doing, Partha, it's going smooth.
Okay, fine.
As of now.
Fine. Thank you.
Final submission need to happen, but all the 2 candidates I have scored
Right, sir. Right, sir. I hope
Welcome, Dr.
all our
Natarajan.
judges are having no difficulties. Carry on, Feroz, please.
Unmute.
Yeah. Thank you, Dr. Partha. So far, it's going great. So we have a third speaker of the day, the young and vibrant Dr. Karan Bhatia. And I would request our dynamic scientific committee member, Dr. Krishna Prasad, to do the introduction for Dr. Karan Bhatia.
Thank you,
Over to
Feroz.
Dr. Bhatia.
Thank you, Feroz. So it's my pleasure to introduce my friend Karan Bhatia. I think we have been seeing him so many of the AIOC form. He's also, I think, Joint Secretary for Young Ophthalmology Society of India, also editor in for YouTube. And along with that, he has done his MBBS from Kasturba Medical College, Manipal, and he has done his fellowship under two dynamic surgeons, that is Dr. K.V. Satyamurthy and Dr. Krishna Prasad from Hubli. Basically, he is a phaco-refractive person who is doing a tremendous job. He got a fellowship in a different hospital like Apollo. He has trained under Dr. Rajesh Fogla. He was in Venu Eye Hospital. He was in Arvind Eye Hospital. He has done his DN in Arvind Eye Hospital. So apart from that, he has got a lot of publications in different journals. So he has got a lot to think to talk. I think I'll not tell everything about his biodata. Over to you, Karan Bhatia.
Before I forget, I would request all the contestants to start sharing your slide when the introduction is going on. All right, all the best, Karan.
Thank you, sir, for that elaborate discussion introduction. I'll start my presentation now. Mixed aphakia, a novel technique for fixing intraocular lens implantation. No financial interest. So the ideal situation after any cataract surgery is the implantation of a foldable lens into the bag. However, what you don't want is surgical aphakia. Various options like the anterior IOLs, the iris claw IOLs, and the sclera-fixated IOLs have been described. The sclera-fixated IOLs are the most popular approach. Various techniques have been described, but they are a challenge for the anterior segment surgeons. We devised the mixed technique, which the externalized haptic is cauterized to cover plans like the Himalaya technique, and the haptic of the IOL extraocularly introduces a 26-phase needle like stands for modified adaptation, I for Yamane, X for the X technique. This is a surgery that started off with a conic specimen entirely flat. The corneal tunnel was made and likely to go in this case, the anterior lens was removed and the limbus was marked with 1 mm corneal suture marker. Marks 1 was put and mark 1 was to be nasal. Mark 2 was to be temporal to the limbus. Mark 3 was to be mark 1. Mark 4 was to come above the mark. After this, you can see the 3-piece Orolab lens. An angle transconjunctival sclerotomy was done 2 mm from mark needle behind the iris. This needle was cut out as you would do in the case of the next technique. This 26 days later, inside the lumen, the leading haptic of a 3-piece lens was introduced. And slowly, as you're directing the lens into the anterior, the haptic complex was brought out on the sclerotomy side. This haptic was then cauterized to create a flange using the movie cautery. It was done by a Mark 4. And you can see the iris plane. This was also tried to be brought out. However, there is always a difficulty in getting this 26 placement out. And this is the problem that is by the glass surgeons. And then the peeling haptic was removed from the and then this externalized haptic was again cauterized to the flange. The flange was then buried subconjunctivally and then pushed. And you can see how stable and well-centered the IOL is. However, we have a couple of recommendations. The use of an anterior chamber maintainer made our life much more easy. The creation of an eccentric tunnel, as you can see in this case over here, helps to get the second needle out. This second, as a result of which, the trailing haptic can easily be introduced and again made our life very much easier. We treated a plastic stopper using an IV set. It's very simple. It's less expensive than the silicone bands that our surgeons use. And then this plastic stopper was put inside the 26 gauge needle And you can see again the haptic was brought out, the stopper was put into place so that the haptic doesn't slip away. This is left as such, and then the trailing haptic was again externalized as I've shown in the previous video. And then the titration was done to check whether it is stable or not. And then we used a low-cost device, the heat pottery, to create another flange. The stopper was removed. Again, we checked the titration and the stability of the IOL. And then again, the heat pottery flange was created. This was buried inside again. You can see how stable. So 15 eyes, 6 months follow-up. All of them had a BCD of greater than or better than 20 by 30. The mixed technique, easy, fast, and reproducible technique with these advantages of both the Yamane and the X technique. Excellent. Thank you so much.
Thank you, Dr. Karan.
Thank you, ma'am.
Excellent presentation. So may I request our lead judges, Dr. Ajit Babu Maji and Dr. Natarajan. Sir, welcome. Over to you for the discussion.
Is Natarajan there?
He is there. He came in.
Please let him.
He is muted.
Dr. Natarajan, do you want to unmute yourself? Sir, Natarajan, sir, do you want to unmute yourself?
Okay,
let continue, Dr. Ajit Babu. Yeah.
Karan, it's a nice video presentation. Do you claim anything new technique you are doing, or you are following the others, and in your video you are doing better?
So the modification, we started off with about 7-8 cases that we had done, and the challenges that we faced were like, first of all, one case what we had was that the haptic after about 2 or 3 weeks came out. So we had to trim it and put it into position. That is why we came up with the modifications using a stopper, titration, and then checking properly. And once the stability is actually achieved, then only we cauterize and created the flange. What we have done is, as an anterior segment surgeon, I don't want to be always dependent on the VR surgeons, particularly when they are not available. Disclaimer, I will just say one thing, that the anterior segment surgeons must know their limitations, and when they do not know, it is beyond their thing, they should always take a VR consultation. But what I have done over here is, we've combined 2 techniques, easy techniques. Yamane advantage is that you don't have to tuck it inside in a scleral pocket, which I felt a little bit difficulty when I was doing my first SFIs by this technique, where the haptic got crushed, or probably my technique or my handling was not that great in that. And so the flange really worked for me. And the second one was, we are all very much comfortable with small incision cataract surgery, and this way, and when you introduce this haptic outside the eye, as the XNet people from Arvind, Dr. Prabhu has done, is that it's much easier than when you're doing it inside the anterior chamber. And again, I'm an anterior segment surgeon. If anything goes down, it falls, and then I have to call a VR surgeon for a backup. So this was my thinking. I want to take minimum consultation, but if there is a problem, I will always call.
Yeah, but if you see Yamane's technique and this plastic stopper, everyone is practicing these days. I don't know whether you know that fact or not. But as you said, as an anterior segment surgeon, you want to practice this. But how do you manage the vitreous? The number one. Number two, did you encounter any of the iris retraction towards the end or in the postoperative period?
So we did not encounter any iris retraction, but in the initial stages, the insertion of the needle, that sclerotomy, you could sometimes see that there was a bowing over there. So then again, you had to go back and consult your VR surgeons as to what am I doing wrong. So there was always a constant touch. And this article has been accepted for publication in the Indian Journal of Ophthalmology as well. And another thing that we faced was that's about it, sir. It was we always consulted with the VR people as what we're doing wrong, and then made our life easy.
All right, thank you, Dr. Karan and Dr. Natarajan.
Ruth, can I just make a comment?
Yeah,
yes.
Dr. Natarajan is busy.
So I think Karan, a great technique. It's a great mix of best of 2 techniques. The XNet needle I have also used, which comes from Orolab, and the best part is that it is already angled. So you don't have to do that bit, and it's angled to the tune that, because it goes with the IOL, the haptic, the curvature of it matches with the curvature of the IOL haptic. So manipulations are far less when your needle is trying to get that out. So I think Karan has done very nicely, I should say, and very cleverly also, very thoughtful of him to have combined both these things together. He's cauterized this thing also, so the haptic doesn't have to be tucked into a tunnel or doesn't have to be tucked into tuck anywhere. Rather, you can just cauterize it and leave it, and then he's used that X-net needle. So that way, I feel it is a combination, good combination of both. Good.
Rose, can I jump in?
Do we have any other judge?
Yeah, can I speak?
Yes, please.
Yes.
Yeah, Karan, it's a good technique. You're an excellent surgeon. Two things you said. Last word was, I wish you have an AC maintainer. Right? Did you do an entire vitrectomy before putting an iron?
Yes, definitely. So that is one of the most. I saw Ajit sir had asked that question. I then went away with that. I forgot. Sorry, but yes, automated vitrectomy is one of the most important things. Manual vitrectomy is out of the question.
Yeah. Second thing is, when you put an AC maintainer in an incision which is about 5.5 or 6 millimeters, bound to be you're going to have RS pushing out through your incision. How do you manage that?
So some things that what we have done is, see, when the first thing has been produced, the first needle exchange that is taking place, the first externalization, then you switch off the AC maintainer. And then you put visco in, that what we've done, and then we've done it the other second externalization under visco, because what we did not want any fluctuations in the anterior chamber. And one eye that we had faced, it was a young guy that I had done, around 16 years of age, this boy was, and then I had to abandon the procedure because the flange actually came through the sclera into the eye. And so this was, scleral rigidity was very less. So that's a limitation. You should not do it in young guys where the scleral rigidity is, compromised. And so then what, I had to change to a suture technique, and then I didn't wire the suture.
But it's a good technique.
Thank you, sir.
Dr. G.S. Dhami sir, may we ask you to also judge and mark this participant, since Dr. Natarajan sir is busy.
So one more thing that we did is very important is, like, when you're using a 26 gauge needle, it doesn't come out of the second thing. That's what I had shown in the video. So this eccentric tunnel, you create the eccentric tunnel slightly on the righter side to where you put the mark 4, where the second needle has been introduced. As a result of which you have to titrate your incision according to that way, so that that needle comes out. And that, because even VR surgeons, as I have said, our VR surgeon had a difficulty in putting that inside.
Thank you very much, Dr. Karan. Do we have any other judges with their comments?
Can I? Yeah. Yes. Here. You see, all anterior segment surgeons want to get rid of posterior segment surgeons. Point number one. Point number two is that all surgeons, irrespective of their segment, want the easiest technique to be there. Karan, this technique is a simpler technique, very, very simple. But what you have done a great job by combining X-net and Yamanes. But what I would suggest is do 20 cases more, because the main issue is in all these IOLs is to take out the haptic. And that Yamanes technique partial is very, very good. There's no doubt about it. My suggestion would be to combine it with what Amar does, to bury it into this thing for long-term stability. You see, because I am always worried with the cautery part of it, how much flange, erosion, always an issue, because believe me, sleepless nights can happen because of the problem of erosion. Because if my haptic is buried in the sclera, I will never have a sleepless night. So my suggestion is, wonderful technique you have shown. My suggestion would be that haptic externalization is excellent, but try to make a radial cut and bury it inside. You will be much happier.
Thank you, sir.
Thank you very much, sir. Thank all the judges for their pearls of wisdom on this case. So we move on to the next presentation. Dr. Parikshit, do you want to take over?
Yeah, thank you, Dr. Feroz. We have
Parikshit, just one more, reminder that all our judges are marking all our candidates, all our presenters. Yes. So The lead judges are going to ask the lead questions, and then any of the judges can follow. But the marking to be done by all our judges for every presenter.
Thank
Carry
you,
on.
sir. Thank you for the clarification. Now I would request Dr. Neha Jain from Uttar Pradesh. She is speaking on the repeatability of ORB Scan 3. And we again have our two distinguished judges, Dr. Anand Parthsarthi and Dr. Govind S. Dhami. I would request my friend and senior, Dr. Sonu Goyal, a very well-known cataract and refractive surgeon, to introduce Dr. Neha Jain.
So welcome, Neha. Dr. Neha Jain is working as the research head in the Triputi Eye Center, Noida, a very young, dynamic cornea, cataract, and refractive surgeon. She has her graduation and post-graduation from Kasturba, Manipal, and Surat, Gujarat. All to you, Neha.
Thank you so much, sir. Good evening. I'll be presenting on assessing the repeatability of OPSCAN for anterior segment parameters in normal eyes. I'm not able to move it actually.
Please move the cursor. Just click on the screen and move the cursor to right.
Mr. Sunil, if you can help her.
Sorry. So as we know, OPSCAN is a scanning slit elevation-based topographer with advanced Placido disc system. Initially, the OPSCAN 2 was available in the market, which has been followed by a more evolutionized and high-resolution OPSCAN 3 machine, which measures 23,000 points. So when we were going through the literature, we found that there are a lot of articles which are available on the OPSCAN 2 machine. Like this particular article of 2012, which says that the OPSCAN 2 is a non-invasive, repeatable, and reproducible technique for corneal topography evaluation in healthy eyes. Then similarly, in 2017, this particular article, it mentions that the measurements are less repeatable with OPSCAN 2 as compared to Pentacam and Galilei, although overall repeatability was high for all the instruments. Then this article also mentions that the OPSCAN 2 is repeatable and less precise as compared to Pentacam. This particular article published in 2013, it also says that all the three devices, that is OPSCAN 2, Pentacam and Galilei, cannot be considered equivalent, although they all are repeatable. So there was a lacuna in the current knowledge, that is all the articles which we found in the literature were for OPSCAN 2 and no article was there for the repeatability of OPSCAN 3. So the aim of our study was to assess the repeatability of OPSCAN 3 in normal eyes for the following parameters, that is steep keratometry, flat keratometry, thinnest corneal thickness, anterior chamber depth, wide to wide diameter, and 3 mm and 5 mm zonal irregularity. This was a prospective observational study done in Noida over a period of 15 days where 100 eyes of 50 participants were tested in accordance with the inclusion and the exclusion criteria. Visual acuity for distance and near was checked, which was followed by a thorough slit lamp examination and dilated fundus evaluation. The inclusion criteria were age 10 to 35 years, participants were cooperative to sit through the examination scans, emetropia, myopia up to -2 diopter, hypermetropia up to +2 diopters, BCV of 6/6 in both the eyes, and no anterior or posterior segment pathology. Exclusion criteria were refractive error more than -2 and more than +2 diopter, presence of any active ocular surface disease, any posterior segment pathology, history of any systemic or neurological disorder affecting the pupil size, use of any ocular topical medication, previous history of using extended wear contact lenses, abnormal corneal topography, or any clinical significant lenticular opacity. So OPSCAN 3 was done in one eye 3 consecutive time at interval of 5 minutes, and after that the procedure was repeated in the other eye and all the parameters were noted. The scans were done under similar lighting condition for all patients and done by the same operator. The data was analyzed using the MedCalc version 19.4.1. So as you can see, for the keratometry, TCT, and the WTW, the ICC, that is the coefficient, was more than 0.9, which basically means that the measurements are repeatable, and the COV was closer to 1%, which again means the measurements are repeatable. The TRT values as compared to the ones found in the previous studies were correlating, which means that all the measurements were found to be repeatable. Similarly, for the irregularity and the ACD also, the significance was more than 0.05, which means that the values were repeatable. So hence we can conclude that OPSCAN 3 is a non-invasive and repeatable modality for evaluation of cornea, and this study can form a basis for evaluation to compare the readings of the different instruments also, and to find the values if they're repeatable or not in a diseased eye like keratoconus, etc. Thank you.
Thank you, Doctor, for the very brief and wonderful presentation. Doctor, may I request Dr. Anand Parthsarthi, sir, to...
Thank you. Thank you, Parikshit. Very nice presentation, Neha. I did see that you've actually taken 4 of the parameters. For me, as an anti-corneal surgeon, just like you, I'm sure there are a couple of other parameters which are extremely important in a refractive surgery practice. And that's something that I would have really liked for you to probably emphasize more. Keratometry, yes, and I think an important point to emphasize should have been in terms of how you made it. Did you use artificial drops? Because in any slit channel microscope, the tear film makes an extremely, extremely important role. And that would have been probably should have been emphasized whether you used any pre-scan eye drops like lubricant.
So we have not used one, but I'll mention it the next time. I should have mentioned it. We have not used any drops.
And broadly, there have been multiple studies, Neha, which have already emphasized that when you're using different technologies across platforms like a Shine Plug and OpScan, some parameters may not actually be comparable. And there is as recent a study in May 2020 in cornea, which compared OpScan 3, exactly what you did, compared it with a Pentacam HR. And those parameters can actually not be interchangeable. So if you're following up a patient for, let's say, keratoconus, it's important that you use the same machine or a similar make of the machine across, because when you are deciding on intervention, this becomes important. So if you're doing OpScan 3 for looking at repeatability for treatment, then you would need to probably repeat this on the same machine. The other thing is important factor, especially in a slit scanning, is important whether the anterior chamber depth. Did you look at that? I think for me that is important.
We did look, so that was found to be repeatable.
Okay, all right, because that was not mentioned in the presentation.
It was there in the second table, actually, I think.
And in terms, there's one other thing I would have probably want. Did you actually do any inter-observer variation?
No, sir, we've not done that. It was like a pilot study we had actually started doing, which we plan to follow it up with more number of patients and other diseased eyes also. For this one, we had not done. Only I had done all the scans for the patients.
I would probably just suggest one thing if you're going to look at publication, Neha. One would be to look at a Bland Altman plot to see if what you do and what somebody else, is there any variation. It will make the paper really, really good.
Okay.
And that's all from my side.
Thank you for the suggestion, sir.
Dr. Dhami, sir. So if you can unmute yourself, sir. Dhami, sir.
Thank you. Sorry for that. It's a good presentation. Nicely, you have taken good idea, good readings, and a good reference to the literature. Neha, my first question is this test was done on a virgin eye or the eye was tested for something else before this? That will rule out the quality of the tear film you are trying to analyze while doing OpScan. Secondly, Dr. Anand mentioned very nicely, did you use any eye drops, tear drops before making the observations or not?
No, sir.
Thirdly,
just done the visual acuity testing. That's it.
That's it. Then third is, did you really give a gap in between the readings? You said about 5 minutes.
5 minutes.
What was the blink rate then, and what was the quality of the tear film during that period? Matters a very important, plays a very important role, as good as you are going to compare the consecutive results.
Okay.
It's a good study, but I feel more role of tear film and ocular surface disease in regulating your readings is more important.
Okay. We'll keep in mind. Thank you, sir.
Any other questions by any other judges for Dr. Neha? Dr. Namrata, ma'am. Okay, so Dr. Fairuz, we can go on to the next speaker.
All right. Yes. So we go on to the next presenter of today, Dr. Nitin Mehrotra, who will be presenting on post-phakic ICL implantation, Urezavalia syndrome. And I request my dear colleague, the scientific committee member, the ever-energetic Dr. Somshila Murthy, to introduce Dr. Mehrotra today. Dr. Somshila?
Thank you very much, Feroz. I think that this has been yet another very exciting meeting for all of us, and looking at the talented youngsters who are presenting, it's just really gets me that I wish we had done half as much as they had done. So going on to introducing Dr. Nitin, it's a very brief introduction, and for some reason I had actually prepared one slide and that's not playing.
You can verbally introduce Dr. Mehrotra. Dr. Somshila? Dr. Somshila?
Yeah, I'm sorry, Feroz. I think it's connection.
No. So we are verbally introducing the participants. Hello? Dr. Somshila, are you there?
Yes, I'm here. Can you hear me?
And we were not able to hear you.
I'm so sorry. I switched off my video. Sorry about that. So Dr. Nitin Mehrotra did his post-graduation from SN Medical College in Agra. And he also did his specialty training at Dr. Shroff's Charitable Eye Hospital in New Delhi. And he finished that in strabismus and pediatric ophthalmology. And at his young age, he's presently working as an assistant professor in Government Medical College in Haldwani. So his fields of interest are obviously pediatric ophthalmology and also cataract and refractive surgery. So hand over to Nitin. All the best to you. And please remember to stay to the time so that you'll be up in the running.
Thank you, ma'am. Good evening. I am going to present a case of 30-year-old male myopic patient with a myopia of -17 diopter in right eye, -16 diopter in left eye. Patient came for refractive surgery. We advised patient phakic ICL. For that, as a protocol, we measured all the parameters with optical biometer IL Master 700 and with digital caliper. The important measurements are highlighted. The internal anterior chamber depth was adequate in both the eyes, 3.18 in right eye and 3.2 in the left eye. And the white-to-white horizontal diameter with the digital caliper was almost equal in both the eyes, 12.3 and 12.04. So the patient received Visian ICL centraflow of 13.2 millimeter for both the eyes. First, the left eye was operated. The vision post-operatively was 6/6, and the vault was adequate of about 510 microns. After 5 days, we went ahead with the surgery in the right eye. To our surprise, patient in post-operative period has a rise in IOP with mild corneal edema, shallow anterior chamber, and the pupil was mid-dilated, and the vault was around 1100 to 1200 microns. So since we have implanted the central flow ICL, the pupillary block is rare with it. So we considered it the retained methyl cellulose, which is responsible for the rise in IOP, and mid-dilated pupil can be due to iris stuck at the periphery. After controlling intraocular pressure, next day we take the patient for AC wash and ICL repositioning, to which the patient did responded well. The visual acuity improved to 6/12. The ICL vault reduced to about 1000 microns, which was an acceptable limit. And the pupil was still mid-dilated and didn't respond to pilocarpine. We keep the patient on follow-up. On subsequent follow-up after 2 months, patient came with decreasing vision and patient developed anterior subcapsular cataract. Pupil was still dilated. Now the patient also had pigment dispersion. On gonioscopy, the angles were open and the TM was highly pigmented. IOP was normal and patient was not on anti-glaucoma medication. We went through literature and we saw there were few case reports and they were having similar presentation, and they diagnosed those cases to be having the Urezavalia syndrome, which was first described in 1963 in post-keratoplasty patients in keratoconus, in which the patient presented with fixed dilated pupil and the anterior subcapsular cataract. We we considered our patient to be having the Urey-Chevalier syndrome, and we explained it to the patient, and we planned patient for ICL removal and followed by cataract surgery and implantation of hydrophobic single piece hydrophobic IOL of +6 diopters. This is a short video which was showing how the ICL was explanted. After making the main incision, the 2 side ports are made and the haptic is brought into the anterior chamber, one of the haptic, and by the 2 hand technique, hand over hand technique, the ICL can be removed swiftly from the anterior chamber, followed by a routine cataract surgery, and the IOL was implanted. This is the picture of the patient presently. Now the visual acuity has improved, is now maintained at 6/12. Pupil now has come down to 4 to 5 millimeter, but still it is atonic. So what I want to give a message here is that although the successful surgery was being carried out in one eye, it doesn't mean that the other eye will not have problem. And despite we follow the protocol for ICL sizing, post-operative surprises can be seen. Although the Urey-Chevalier syndrome is rare, it should be considered in unusual outcomes. Thank you.
Thank you so much, Dr. Mehrotra. Brilliant presentation. May I request our judges, Dr. Anand Parthasarathy and Dr. Dami, to lead the discussion of this case. Over to you, Dr. Parthasarathy.
I did like the presentation, but there were just a couple of things I would probably want you to focus on, Nitin. One was that the incidence after a standard keratoplasty, usually how many patients, because it was first described in a keratoplasty patient. So do you know the incidence?
So it's very rare, sir.
Okay, it's about 16%. So 1 in 6 to 8 patients would actually get it if in a keratoplasty patient. So what is important to note, Nitin, is that you need to know why it occurred, and
Yes,
especially I must say you've been very brave to do it in a doctor.
Yes.
So I think for me, I would have been a lot more careful. It's not that you do not get iris pupillary block or a raised IOP in central flow patients. I think it's just that it's the amount of viscoelastic that you put in and how much you put out. So I would definitely sincerely request to have a look at the surgery itself to see why it really occurred. Because for a refractive surgery patient to have something similar, I would definitely be not a good outcome for that patient for sure.
Yes, sir.
The other thing is it's very unlikely because of the pathophysiology. Do you know the pathophysiology for Urey-Chevalier, Nitin? I'm sure you know that, right?
Yes, sir. Yes, sir. It's due to the ischemia of the iris, most commonly due to the raised IOP, sir.
Perfect. So it's very unlikely that pilocarpine would actually work in these patients.
Yes, sir. Yes,
right?
sir.
So
Yes,
I think that's one point I would have probably told you, just to make sure that in management, that may not be the most ideal one. The third point is, even if you are looking at treating these patients, if you want to treat the dilated pupil, did the patient complain about glare after surgery?
Yes, sir. Yes, sir. Patient on the follow-up, patient always complain of glare because of dilated pupil, sir.
So would you think about doing maybe a pupilloplasty? Do you think that might be an option you would consider?
Yes, sir. Yes, sir. If the patient didn't develop the cataract, then that was a good option for this patient. But since the patient has developed cataract and it was visually significant, and patient vision dropped from 6/12 post-operatively to 6/24, that patient was constantly complaining.
Nitin, I think it's unusual, definitely a rare, definitely and it's probably a learning for all of us to see also that the plastic that we use tends to play such an important role. Good presentation. That's all.
Thanks, sir. Thanks, sir.
Thank you, Dr. Parthasarathy. May I request Dr. Dami to take over the discussion?
Nitin,
yes,
you presented a very good case. I have only 2 suggestions.
Yes, sir.
Did you use pilocarpine after putting the ICL?
No, sir. No, sir.
Number 1. See, what pilocarpine does is it removes the iris tag tucking into the periphery of the ICL.
Yes, sir.
Right?
Yes, sir.
Once you had a dilated pupil, Though Dr. Anand has explained you excellent, all the theoretical work, ischemia and whatnot, one practical approach I would have gone is just gone into the eye and dilated the pupil and dialed the lens to a second position. Moment you dial the lens to a second position, whether it was horizontal first or a vertical later, I think you can relieve whatever adhesion was there or whether remnant methyl cell was there, or I 100% sure the missizing of the ICL would be checked immediately and you might get a relief from the dilated pupil as you are saying. Otherwise, explantation of the IOL, resizing is the alternative.
Yes, sir.
That is the reason if you put a pillow card immediately post-op, though most of us have stopped. Most of us have stopped using a viscoelastic while inserting an ICL, but that's not advised for everyone.
Yes, sir.
Pilocarpine post-op immediately on the table, tap on the ICL center will give you your place next morning.
Yes,
I think you got a good case and it teaches a lot of us.
Yes. Thanks.
Thank you very much, sir. It's so evident that, from each case, I'm sure everyone is learning, and all these young talents who have come in here. It's so much of a learning that's happening over here. Do we have any other judge who want to quickly?
I want Nitin, in
Yes, sir.
your UBM, if you see the lens is tilted, one side of the lens is tilted up. Did you
OCT, sir.
notice that? And
On
you,
OCT.
yeah.
No, opposite.
Yes, sir.
ASOCity.
Yes, sir. Yes, sir.
ASOCity. What
Yes, sir.
what could be the reason for that? I don't know because I am a posterior segment surgeon. I don't know, but I can definitely say there is a tilt and there is a pressing on the posterior surface of the iris.
Yes, sir. I was even said that could be a cause of because it can be a oversized ICL, sir. In this case, that could also be a cause of giving this kind of picture, sir. But sir, since the measurements were almost similar for both the eyes, so and when we operated this in the second eye, the sizing of the ICL could be a problem also, sir. Definitely, sir. Definitely.
Because it was present even after the visco wash.
Yes, sir. Yes, sir. Yes, sir. It was present even after.
Thank you, Dr. Ajit. So, Dr. Parikshit, can we go on to the next speaker?
Yes, doctor. So now we invite Dr. Sahil Bhandari from Rajasthan. He'll be speaking on C-rexes, the surgical grail in intumescent mature cataract. And we have Padma Shri Professor T.P. Lahane sir and Dr. Anand Parthsarthi as the lead judges. And I would request Dr. Sumashila Murthy, one of the most scientific amongst us all scientific committee members, to introduce Dr. Sahil.
Parikshit, can you just take this up? My connection is unstable. I'm sorry.
Okay. So, Dr. Sahil, I think we should go on with your presentation since we are short of time. Yeah.
I can do a quick introduction of the speaker, Dr. Sahil.
Yeah. Yes,
Okay.
please do that, ma'am.
Yes. Give me just a second. Yeah, so it's a pleasure to have Sahil here, and Sahil has great expertise in various surgical specialties, and also he has been a part of various community eye care management, and his core competencies are that his expertise in managing patients of various subspecialties together, even including vitreoretinal surgery. So he has proved his academic excellence in various forums and various sessions throughout, presenting papers, posters, and everything. And currently he is a consultant ophthalmologist at Guru Hasti Chikisalaya, Pipar City, Jodhpur. And he is an alumni of All India Institute of Medical Science. Over to you, Dr. Sahil. We are looking forward to it. All the very
He was
best.
even Arvind alumni also.
Yeah.
And he was the recipient of the SNEC Award Fellowship, which Partha started with the SNEC ARC Fellowship. So he was the recipient of the SNEC fellowship.
Thank you, sir. Thank you for the gentle words and gentle introduction. I would start my presentation, and thank you, AIOC Scientific Committee, for giving me this opportunity. I am here to present a small technique, a small modification which is available and can be done by every NTA segment surgeon, which is called a C-Rexis, which is considered to be a surgical grail for intumescent mature cataract. Well, when I see something like this, a well good white, milky white mature cataract, my will go zoom. So I like to operate, every anterior segment would like to operate it as and when it is available to them. But and when we reach into the intraoperative phase and we make the first nick with the 26 gauge needle and we see a small extension going into the through and through extension and showing us an Argentina flag sign, it's a boom for us. So that's a nightmare many a times. And prevention is the best cure for this kind of Argentina flag sign. So what all can we do to prevent it? Well, there are multiple techniques available in throughout the literature, but the starting with the low cost technique and a small modification is the C-Rexis. You can extend your cost and then you can go up to Zepto, you can go up to Femto, depends upon what high cost activity surgeon would like to adapt. But why C-Rexis? Why I am promoting this? Why we had a modified technique called as C-Rexis, and why any surgeon can adapt to is the reason is that it is available for both phaco and SICS. So it can be done through 2.2 mm clear corneal, through side port, 2.8 mm clear corneal, through 5 mm sclerocorneal, 6 mm sclerocorneal, anything. So anything of the cataract surgery method can be used and C-Rexis can be done. It is very cost effective. Rather, it does not add into any cost, because in your armamentarium, in any other cataract surgeon's armamentarium, you will always have 26 gauge cystitome, you will always have air cannula, you will always have your access forceps. So those all things are already available. The only thing which we are doing is making it in a modified way so that it suits your need and it makes your surgical better in the intumescent mature cataracts. And regarding success, yes, it is very much equivalent to other high-end, high-cost technique also. Why is so? Why? What is the physics behind it? Why is it a successful technique with a small modification? Well, the main reason is simultaneously acting unidirectional vector forces. What does that mean? If you look into the pictorial representation, we made a small C from center to paracentral with one brisk stroke using 26 gauge cystitome. So that is the main concept, that as soon as you make when one stroke, one brisk stroke, a C-shaped flap, you have vector forces which are acting all throughout the flap, and also they are acting towards a single same direction on both the arms of the C. So both the arms of the C are also having same directional force. When you compare it to the conventional one, there are two forces which are acting opposite direction. So that is the main risk, and this is the main physics or funda behind
1 minute
C-Rexis,
left.
is that it will not be causing a bidirectional flow, and thus the intralentricular pressure will be relieved on the flap and it can be easily turned over and Rexis can be continued. This is the video which shows a small brisk one stroke C flap. The flap is elevated. You can easily remove the cortical fluid behind it. Put routine visco, no need of or cohesive one, only dispersive can also work out. And then you can continue with the help of 26 gauge cystitome. In phaco techniques, again, same one stroke, single stroke, brisk C-Rexis flap. So that is the main thing which is behind it from center to paracenter. You aspirate the fluid also comes out like a smoke storm kind of thing from the center to the center of the anterior chamber. And that's it. You can then continue it with the help of your access forceps. We did a study in which 125 eyes were included. Both SICS and PICO were done, and single surgeon did it. And none of these cases had capsular tags and Rexis extension. The same was published over here in 2016. Thank you very much, sir.
Thank you, Dr. Sahil, for the wonderful presentation, and that you included both SICS and phaco surgeries. I would request Professor T.P. Lahane, who's done more than 100,000 cataract surgeries, to give his comments and ask you questions.
Sahil, you did an excellent presentation. The C-Rexis, modified C-Rexis is very good, because whenever we are doing in intumescent cataract, and if you take a straight incision, any straight incision in the capsule, so that tears. And if that incision is curved, that may be C-shaped, that may be V-shaped, or any other shape, that always helps. So you have done this C type of rhexis. So is it possible to others to do it like the same way?
Yes, sir, it's very well repeatable because technically whenever we are making a simple rhexis in a circular curvilinear rhexis, we already have kind of V-shaped flap, or we really generally take the stroke of 26 gauge needle in a little curvilinear manner. So that curvilinear manner has to be modified and has to extend a little bit more. That is the only thing which a surgeon needs to practice. So any surgeon who is practicing cataract can very well adapt.
It means it is a C or V, whatever. It should be a curve. One.
Yes, sir.
Secondly, have you tried other, because we see this small circle is done in the center, or other techniques in the you can say intumescent cataract. Have you tried those techniques?
Yes, sir. I have tried those techniques also, in which mainly with the small neck, small rhexis first, double rhexis kind of thing, or directly go with the 30 gauge needle or 26 gauge needle, enter the anterior capsule and aspirate the fluid. But somehow I have seen that since I have been doing cataract surgery, it is a kind of modification of the routine technique only. It's not something way beyond your routine technique. So it is much easier to adapt it and much easier to do it. Even though, yes, I have faced some problems in the initial course of the learning phase, but the main concept behind the C flap was a C-shaped flap with one brisk stroke in a single time and from center to paracenter. So changes in the position can obviously lead into extension in any kind of cases. So that would be much better to adapt to the structure-wise C rhexis.
What was the initial problems when you started doing this?
Main initial problems were the creation of the adequate size flap in one stroke. So it was like the stroke used to end up in between, and then that used to go in a ragged manner. So that was the main issue, and then that would lead into a little bit of extension here and then we had to switch over to the Warners or cut the rhexis flap and then go ahead with the other techniques. So that was the main issues initially as a learning part.
Thank you, Sahil. It was a beautiful presentation. Congratulations.
Thank you, sir.
I just have a comment, Sahil. This is a technique, I think, which has been published 3-4 years ago, if I'm not mistaken.
Yes, ma'am.
Dr. Anand.
So one small comment can I make?
Yes, sir.
I have no right to comment on cataract surgery once Professor Lahane has commented, and and the reason I am commenting is because Dr. Lahane uttered one word that you see. Therefore, I was tempted to just a humor point of view. It should be called as brisk non-linear rhexis. That's all. You see, because Professor Lahane said it can be C shape, V shape, any shape. Because you want, instead of one vector, you want two vectors basically. So it should not be linear. So the two words you emphasized, non-linear and brisk. So it should be known as brisk non-linear rhexis rather than C. Why emphasize C? When Lahane says, because Lahane is the messiah of SICS in the country. So once Lahane says, it should be, any other shape except linear. So terminology should be, maybe you can derive it, brisk non-linear rhexis. That's it.
Awesome.
Thank you, sir.
Sir, Lahane sir.
Namaskar.
What I'm saying is terminology, sir. आप बताएं.
I think you are very correct, because okay, whatever the shape he means, but I think as an innovation, he has done it as C shape.
Yeah, he did a great job. But what I was saying is, instead of saying C, because सब लोग C में रख जाएंगे ना, whereas C does not matter.
Yes, C does not matter. Yes, it should not.
That is the reason. Yeah.
Yes, any shape, but not straight. That is
इसलिए.
Because that is not a straight cataract. That is intumescent cataract.
इसलिए मैं कहता brisk non-linear. That's it.
Yes, non-linear. Correct.
Anand sir, please unmute yourself.
He's unmuted here. Yeah.
No. Very difficult to speak after Lahane sir and Verma sir, but I think the L of Lahane and V of Verma should be enough to give. A serious note for Sahil, I think the factor in intumescent cataract is very important. Is the amount of intumescence that you have in a cataract. All intumescent cataract are not the same. The first couple of videos that you showed had very less liquid cortex. So those were very unlikely to extend even if you went ahead with the standard double small rhexis. I think the whiter the cataract, more likely you're going to have an extension. And I think the important part other than the Rexus is the fluid aspiration, which needs to be done either with the Simcoe or ideally with a pressured anterior chamber. So if you use a bimanual and then do the aspiration of the cortex, it's probably very, very unlikely you have an extension. So Sahil, my question is, did you only use a cannula for aspiration of the cortex, or did you use a bimanual, or did you use only Simcoe? Because I think for me that is as important as the Rexus itself.
No, so we technically used only the air cannula for the aspiration of the fluid cortex. It's from under the flap or surrounding of the flap. We did not use any kind of bimanual or this thing, and that was the main thing. Like projection of this technique or modification is that we routinely whatever we are doing in our routine steps are the most commonly implemented in this technique also. So the same thing can be continued and at the comfort level of the surgeon. And we had not tried any kind of bimanual or Simcoe based aspiration in these things.
Learning point for me, I think in all intumescent cataracts, the capsule is actually very fragile, and when you're using a metal cannula to going around trying to remove aspiration, you may have to be very careful that you may nick the Rexus. Just a learning point. So for newer surgeons, it may not be the most ideal one to start off with. That is my
yes, sir. That also that is the main thing. Also, one more thing, another thing, sir. That whenever we used to do a hydro cannula, I mean air cannula aspiration, even if we touch the flap or elevated the flap or touch the edges of the flap, it actually did not extend up to beyond few microns, because the main thing is you are aspirating the fluid, you're reducing the interventricular pressure. Plus, the ventricular pressure is not acting on one single particular point or 1 or 2 points only. It is acting all across the margin of the C-rexis. So the point-wise pressure is really less. So if we many times when we do, we really lead into that the flap is little bit elevated, lifts little bit, moves away, but it actually does not lead into any kind of gross extension as such. So that is the one benefit of this thing, that when you have a good flap, C-rexis flap, you can just lift it up, aspirate it from under it, from the side, without being kind of extra cautious and not leading into any grave danger or grave complications. So that is one benefit of the C flap.
Sahil, can I make a point?
Gauge of the cannula might be a better one, because the air cannula sometimes can be quite fine. So 25, 26 with liquefied cortex might be quite tough unless you.
Yes, sir.
Yes, sir. Sahil, am I audible?
Yes, sir. You are.
Yes, sir.
Well, it's a very good presentation, but what are the in the bag once you puncture it? There are fluid spaces, and once you puncture it, these fluid spaces are going to create a pressure on the nucleus. They are behind the nucleus, they are in front of the nucleus. So you got to be very manipulative. You ought to be knowing how much is the fluid or how many fluid spaces are there in the bag before you puncture it. Now, once you make the first puncture, whether it is continuous or it's non-continuous or non-linear, those fluid spaces are going to displace the fluid through that small little nick you have made. That
yes, sir.
You got to be very, very alert and conscious about it.
Yes, sir.
You ought to be knowing before making a puncture that there are fluid spaces or there are not fluid spaces. You can easily see it on a slit lamp.
Yes, sir.
Thank you, sir. Those were really wonderful comments from iconic ophthalmologist of the country on Dr. Sahil's technique. So I would now request Dr. Fairuz if we can have the next participant.
Yes. So it's a pleasure to have Dr. Samendra Karkur, who's our next speaker, presenting his excellent talk on the management of dislocated nucleus with corneal opacity. So I would invite Dr. Jatinder Balla to introduce Dr. Karkur. Over to you, Dr. Balla.
Yeah, I think we have had very excellent presentations by the young Turks of Central Zone. And adding on to the list, we have the next speaker, Dr. Samendra Karkur, who after doing his post-graduation from PGI Chandigarh, also did vitreoretina uveitis fellowship from the same place. And then he has also done FICO and FICO in uveitis and ocular immunology. He's also a visiting instructor at Byers Eye Institute and Spencer Center for Vision Research, Stanford University, California, and is right now serving as assistant professor at AIMS Bhopal. Over to you, Dr. Samendra, for your presentation. All the best.
Thank you, Dr.
Thank you,
Balla.
sir. Good evening, esteemed judges, scientific committee chairperson and members,
Dr. Karthik,
and
do
my
you
dear
want to
colleagues.
share your screen, please? Yeah. So whenever the introduction is going on, I would request all the speakers to start, sharing your screen.
Okay. Thank you all for this opportunity. My presentation is a new technique which combines both anterior and posterior segment again, and we have published it for the first time in BMJ case reports. My case presentation is incorporated into the video itself, and the commentary is by me only.
Dr. Samendra, can you just stop and restart?
Audio is not coming. Audio is not coming. Samrendra,
Dr. Samendra, can you stop?
Samrendra, your audio is not coming.
Dr. Samendra?
He will give the summary. He will give the running.
No, the
Yes.
audio is not coming.
Can
Samrendra,
you just start the audio?
we can't hear your audio at all.
1 minute. Dr. Samendra, stop your
Yes.
video and Mr.
Okay.
Sunil is going to guide you. Mr. Sunil, please.
Doctor, can you just check box the audio box which I told you in the beginning? First stop share. Doctor, please stop share first.
Samrendra, stop the share. Sunilji, you got to
Yes,
speak a little louder, I think.
Stop the share. Dr. Samendra, can you just click on stop share, screen share once?
Yes, it's already stopped.
Yes, just click on screen share button once.
Okay.
On the left hand side bottom, just click the box which says share computer sound.
Okay. Okay.
And now restart your presentation, sir.
Okay. Thank you. Thank you.
A 32-year-old male presented with bilateral diminution of vision for last 10 years. In the right eye, the vision was light perception 8 on 10, and in the left eye was light perception with accurate projection of rays. Based on the ultrasound and UBM findings, we decided to operate the left eye since right eye was inoperable. Corneal dimensions were measured using calipers in order to decide the size of host button. Corneal center was marked and host button was cut out using trephine. Deep anterior stromal dissection was carried out using crescent knife and blunt dissection. Host button was removed, leaving behind Descemet's membrane and a thin film of stroma. Visualization of the anterior chamber details was possible, hence sclerostomy ports were made and vitrectomy was started. After completion of core vitrectomy, due to the hard nature of the dropped nucleus, decision to use phaco-fragmentation was taken. Localized peritomy was performed and 20-gauge MVR knife was used to make fourth port for phaco-fragmentation probe. Phaco-fragmentation was started due to the scarring of deep residual corneal stroma and non-dilating pupil. The view was limited throughout the procedure. After completion of the phaco-fragmentation of the nucleus, the fourth port was closed using vicryl sutures. Residual vitrectomy was completed with base dissection and peripheral fundus examination was performed. Remaining vitrectomy ports were removed and closed using vicryl sutures. host surface was washed and donor button was placed. After placement of the cardinal sutures, the donor button was secured using interrupted sutures. Post-operative period was uneventful and best corrected visual acuity at 1 month was counting fingers at 3 meters. On slit lamp examination, graft button and graft host interface was clear, sutures were healthy and AC was well formed.
Excellent, Dr. Samendra. And may I request our esteemed judges, Dr. Biswas and Dr. Ajit Babu Maji, to lead the discussion. Dr. Biswas?
So this is not uveitis, so I won't make any comment. I am interested only in the corneal button which has been removed. What was the cause of corneal opacity?
Sir, this patient, he was a young patient, 25-year-old. He had bilateral corneal opacity and the corneal diameter vertical was 9 millimeters. We tried to look for any syndromic correlation. We got the systemic evaluation done, but we couldn't really find any. And he had bilateral nucleus dislocation, and the nucleus was very sclerotic at such a young age. So we did consider any syndromic or a we did take a good history. We got the evaluation done, but we couldn't find any
Somebody looked into
reason
the
for that.
corneal pathology, corneal button which has been removed.
Sir, that was that was one thing which we missed. The button was discarded, and all we could do was we regret. We wanted to send it for histopathology actually, but that was an opportunity missed by us.
I understand.
Whatever Biswas has pointed out is very, very important. Overall, you have done a great job of DLK, and then the visibility is quite good. You can see the vessels and second order vessels also. From there to nucleus removal, instead of having a fourth port of 20 gauge, you could have done a hybrid, two 23 gauge and 23 or 25 and one 20 gauge. Still, you could have managed it.
Yes, sir. Sir, we do use that technique in our surgeries. But in this case, in particular, I made the fourth port because I did not want to disturb any of my 3 standard ports. I used the fourth port only for fragmentation. I closed it immediately afterwards.
Why do you want not to disturb the 3 ports?
Sir, because in order to use fragmentome, I would have to make 20 gauge port.
Yeah, that's what I'm saying. Hybrid is 223 or 25 gauge, and one is 20 gauge.
Yes, sir.
Once fragmentome is done, you could have passed the sutures and make it watertight, and you use rest of the vitrectomy you can complete.
Yes. So we had a personal limitation at the moment. We didn't have a 20 gauge cutter actually. We had only 23 and 25. So this was also one of the reasons. Yes.
Yeah. At pathology, definitely the corneal buttons should be sent for pathology.
Don't
I
worry.
agree, sir. I agree.
Aruz, I just want to make a comment. I think it was a very tough case from cornea point of view also. Small cornea, the size of the cornea is small. It is opacified, and then you go and do a VR surgery through that. I mean, I think it was, to me, I thought it was done very well, except for the button. But I think a very tough case and tough call to take.
Yeah, I also wanted to say the same thing, Saminder. AIMS Bhopal has actually competed with AIMS New Delhi.
AIMS RP Center. I was also wanting to say that.
Excellent job done, excellent surgery, Saminder. And it was a treat to watch this surgery. And other thing which you obviated was otherwise this would have been an endoscopic kind of surgery and a messy surgery. And I agree that you see making another port Because the fluidics get disturbed in case you convert from 20 to 23 and put one suture. Although Ajit Babu is right, we do a lot of hybrid vitrectomies, but excellent surgery done. So I said AIMS Bhopal equivalent to AIMS New Delhi. Great job.
Brilliant.
Samendra, how many publications you have?
Sir, I have around 25, 26 publications.
You have to understand
Quite
that.
a lot, boss, at this age.
First question, when I worked with him, he has 456 publications.
Who?
Just
JB, and he's in the top 2% of the
Yeah.
scientists.
JB, I know. JB has.
Congratulations. I think that's
Congratulations, sir.
Not only congratulations, I think every youngster has to learn. He sees opportunity for publication in every day. And even today, I send anything you remove, send it to him. From 84, I'm doing that. JB?
Sir, I regret till date not having sent that button for histopathology. It was due to some issue during the surgery that we lost it. But yes.
Other eye, Samendra, other eye.
So which is
Other eye.
But what I'm saying,
other eye, sir, is a blind eye. It had total cupping, and there was a complete.
But what I'm suggesting is you can have any graft put there, but take that tissue and send. Na?
Okay.
You can, because pathology by and large will be symmetrical.
Yes.
So you can take that button and put any functional or non-functional this thing, because that eye visual prognosis is in any case nil. So at least tissue will be available. And what Ajit Babu and Biswas and Namrata, everybody is saying about the button, so at least you'll have some tissue.
Okay.
That is my suggestion.
Anand, do you have any questions?
A couple of questions and a couple of comments as well. A very nice video, but I was quite curious to ask you why the choice for DALC was because of the reducing the chances of rejection. Is that the only reason why you prefer DALC?
Sir, the choice for DALC was twofold. The reasons were twofold. One was obviously to prevent the chances of rejection, because we know that the endothelium transplant increases the chances of rejection. Second thing was to prevent post-operative spikes that are usually found in full thickness keratoplasty because of increased inflammation. And the most important thing, sir, was we wanted to avoid the use of keratoprosthesis assisted pars plana vitrectomy, because this was a small eye, and keratoprosthesis adds an extra step in the whole surgery. And the suturing of keratoprosthesis, removal, and then putting the full thickness graft. So we were ready with the whole thing, and we gave it a try. If the Descemet membrane holds the fluctuations due to fragmentation and everything, we will do a lamellar procedure. But in case if it gives way, we already had the entire paraphernalia ready for a full thickness keratoplasty.
Because I was actually, there have been experiments done on how much of pressure the Descemet membrane can hold. And I would just, for my interest, is that, do you know how much of pressure builds up in the eye when you're doing such a lot of infusion?
Sir, the Descemet membrane can hold about, in kilopascals, I think it's around 20 to 80. I mean, actually, that is the elastic modulus, which is close to 150 to 600 millimeters of mercury.
So,
and in
Samrindra, I also think it was not a purely descemetic DALC. It was slightly pre-descemetic DALC, because there was some stromal fiber still there.
Yes. Deep stroma was left behind, ma'am.
So I think that would have, held it on.
Yes, ma'am. That provided some support to the Descemet membrane. I mean, this complete removal was not possible because the deep stroma was also scarred. So some amount of tissue was
No, I think it was a good decision to leave that stroma behind.
All right. Thank you very much. So, Dr. Parikshit, can we go on to the next speaker?
Yes. The next speaker, we have Dr. Shweta Gupta from Madhya Pradesh, Indore. And she's speaking. Dr. Shweta, you can start uploading your slides. DCR simulation, probability to reality. And we have Dr. Lakshmi ma'am and Professor T.P. Lahane sir as the lead judges. And I would request my friend Dr. Amit Porwal, also from Indore, and perhaps the most curious, questioning, and most active amongst our scientific committee members, to introduce someone from his own city.
Thank you, Parikshit. Am I audible now?
Yes, we can hear you, Dr. Amit.
Yeah. So Dr. Shweta Gupta, basically she did her MS ophthalmology from PGI Chandigarh, and she did her fellowship from in oculoplasty and ocular oncology from L.V. Prasad, Hyderabad. She is presently working as a consultant oculoplasty surgeon in Shankara Eye Hospital, Indore. To tell about her academic achievements, she's got in nutshell n number of presentations at national international level, n number of publications. She's been awarded quite a few awards, and she's also an administrator at Shankara Eye Hospital. She's the chief medical administrator. So over to you, Shweta, and all the best.
Thank you so much, sir, for the kind introduction. So good evening, everyone. I'm going to speak about a DCR simulation model. So the current options for the DCR training are hands-on training and the cadaver dissection courses. The hands-on training is the ideal way to learn any surgery. However, there are certain barriers to it, such as variations in the surgical exposure between different residents, enigma of the surgery, and the ethical concerns. Also, the impact of COVID-19. The best available alternative is the cadaver course, but it may not be feasible always due to high cost, limited availability, and a difficult access in the ophthalmology settings. So in any surgical training, it is very important to start off right, and thus the simulation-based training is the way to go. Just like simulation models in the different surgeries of eye, I'm going to describe a prototype DCR model, which is the first of its kind. It's low cost and easy to assemble. So let us see how it is designed. So a white plastic robotic mask is taken which simulates the skull. After the marking the lacrimal fossa, a balloon is taken and the lacrimal nasal mucosa is made with the help of balloon. This nasal mucosa is placed at its position. A carval plus capsule which resembles the lacrimal sac is then placed and secured on both the sides with the help of micropore. So this model helps the trainee to practice a majority of the steps of DCR. So let us go through the different steps of the surgery through this model. So this is the final assembled design. After palpating the anterior lacrimal bone, the incision is made with the 15 number blade around 12 millimeters. The blunt auricularis dissection is carried out to reach the periosteum. A catspaw retractor is placed and the lacrimal sac is retracted laterally to expose the periosteum. Now an incision is made in the periosteum, and with the help of periosteal elevator, lacrimal fossa is exposed. Now the lacrimal bone is perforated and the osteotomy is started. The Carrison rounger is gently inserted between the bone and the lacrimal and the nasal mucosa to expose the pinkish nasal mucosa. The size of the osteotomy is ensured to be an average size. Now the lacrimal sac flaps are created using a 15 number blade. A vertical incision made from the lacrimal sac fundus to the nasolacrimal duct. With the help of Westcott scissors, this incision is converted into H-shaped incision, making a large anterior flap, and the posterior flaps are trimmed out. Similarly, with the help of Westcott scissors or 50 number blade, lacrimal nasal mucosal flaps are made in the H-shaped fashion, and the anterior flaps are kept long. Now the corresponding anterior flaps of the nasal mucosa and the lacrimal sac flap are secured with the end-to-end apposition using 6-vicryl interrupted suture. 3 such sutures are placed in order to keep the anastomosis secured. At the end, layered closure of orbicularis and skin closure was done with the vicryl suture. So this model will definitely help to continue the surgical training and bridge all the gaps in the training due to certain reasons. And now I am planning to conduct a multi-center study for its validation. I will end my presentation by a quote by Edison: "If there is a way to do it better, let's find it." Thank you so much for the patient listening, and thank you so much for the opportunity.
Yeah, this is really wonderful, Dr. Shweta, because most of the simulation that has been tried so far has been for intraocular cataract surgery, very little for extraocular cataract surgery, which also is, of course, growing in leaps and bounds. I would request Professor Lahane sir to give his comments. I mean, Professor Lahane is not just a prolific cataract surgeon, but he also does a huge amount of lid surgeries and DCRs and even tumors.
The presentation was very good. I think something new in the other surgeries. My question is, from where you got this idea? How this you came to this idea?
Sir, practically speaking, I faced this challenge when I returned back to work from my maternity leave. So that time I thought that I will not be able to hold that kerosene, and I have not be able to do any surgery. Then I went at it directly on the patient. But that idea was kept coming in my mind, that if we can do something like simulation, then it will be not only for the females from the maternity leave, from the for people returning to work from the research fellowships, and or somebody is having their breaks due to COVID-19, and or the new residents and trainings can practice if we have such a simulation model. So that was actually way back 2 years back, but now it came into practice, I make into reality just now, like a few months back.
It is very good. Second is who do the both technique, that is endoscopic and external technique for the DCR. Have you done any DCR by any of these two techniques?
Yes, sir. I usually do with the external and the endoscopic as well. So
which is better?
Sir, endoscopy is also better if you are having a good training. So it depends on the surgeons. Like if they are well versed with the endoscopic anatomy, I think they should consider endoscopic surgeries, because now there is an era of more of a laparoscopic surgeries. So I think we should go into the minimally invasive and micro surgeries.
What literature says, endoscopic or the external, which is better?
Sir, I think I must, I will, for this question, I will definitely say if it will depend on the surgeon's experience, sir. So.
So it was very good. Congratulations.
Thank you, sir.
Thank you, sir.
Shweta?
Lakshmi,
Yes,
Mahesh,
ma'am.
Yeah. Congratulations.
Yes.
I just wanted to know
Thank you,
how
ma'am.
you exactly got the orbicularis layer and the bone layer in the model.
Ma'am, the bone layer is directly from the skull, the plastic white mask which I have used. So that was simulating the bone. And for the orbicularis and skin, I have kept 2 layers of the micropore tape over the lacrimal sac. Below the lacrimal sac, I have put 2 different layers mimicking the periosteal layer and the orbital septum.
You had put all these through the inside, is it? Through the nasal cavity side?
Ma'am, from the nasal cavity side, I have kept only the nasal mucosa, that pink colored balloon which I have kept, that I have kept from the inside part of the mask, and rest of the layers I have kept from the outside.
And I think Dr. Lahane sir has asked a very, very pertinent question. You should have answered it this way, that we have to tailor it to each patient, right?
Yes,
endoscopy versus external. External is definitely the gold standard. You see there, you make the beautiful flaps. So age-wise, etiology-wise, pathology-wise, of course, it's the training. So we have to definitely learn our external DCR very well before we go to endoscopy, and then see what will work better in each of the patients and tailor accordingly. Okay?
Yes, ma'am. Yeah. Completely agree, ma'am. Completely agree. Yeah.
Any other question by any other judges?
This is a very wonderful move, and I think you should see whether many more centers can get it, because this is like the bread and butter for oculoplastic surgery, and we have all been shying away from this surgery. But we have with betadine nasal spray, with betadine oral wash, and with povidone, I don't think we should worry at all, because neurosurgeons are doing 5 hours, 6 hours of bone surgery where they are having so much of aerosol generation. And I don't think for DCR we should worry at all. We should go ahead and start in right earnest and not shy away because of COVID, with of course with all the precautions.
Yes, I'm sure.
But ophthalmologists do shy away from DCRs, ma'am, other than oculoplasty surgeons. Even for questions for cataract, glaucoma, and retina, everybody wants to ask questions. But for DCR, that way, very few. So I will hand over to the DCR
because
specialist.
it's a bloody surgery, that's all. If we take the precautions, it's a nice surgery. You start enjoying it.
Yes, agree, Dr. Lakshmi. Very true.
Feroz, can I add one comment?
One comment, a quick comment, yes.
So
Dr.
quick comment, Shweta, excellent presentation and really happy to see this rather innovative and looks like a very easy to make and maybe like not too much of technology involved in what you did. It's almost literally that anybody can put it together. I think you should really pursue this. I don't know if you need, I don't think you need to patent it, but at least write it up. And then afterwards, it should be like a learning kit in most of the medical colleges or wherever else it could be relevant, at centers where they have trainees and fellows and residents, of course. So
Yes,
great.
yes.
All the best to you.
Yeah, thank you, Dr. Somshila.
DCR surgery is one surgery which is deferred by most of the private practitioners and even in medical colleges. So this is a very good model.
Yeah, exactly.
Thank you, sir.
And most of the simulation models have been made, at Parikshit said, for the intraocular surgery and cataract. Very nice idea, Dr. Shweta, to come up with this simulation model for DCR surgery. I think this will really be very helpful in a lot of places where the surgical training is suffering because of COVID era. I think well done.
Yes, thank you, Dr. Bhalla. I'm planning to conduct actually a multi-center study so that all the novice as well the experienced surgeons can give their feedback and we can like validate and then we can implement in the training for the routine. Thank you, sir.
We go on to the next speaker of the day. We are coming to the fag end of our session, the Central Zone Talent Search. So we have Dr. Tanmay Srivastav, who will be presenting on incidental viral marker positivity in cataract patients. May I request Dr. Somshila Murthy to get Dr. Tanmay Srivastav introduced. Over to you, Dr. Somshila.
Thank you, Feroz. And once again, good evening to all the esteemed judges and all my colleagues and to the wonderful presenters. It's my honor to present one more young talent, Dr. Tanmay Srivastav. He's done his MS Ophthalmology from the Regional Institute of Ophthalmology from BHU Varanasi. And presently, he's a senior resident in the Regional Institute of Ophthalmology at Varanasi again. So, and in his young career so far, he's already published 18 papers in peer-reviewed journals. He has won 8 awards, both at national and at state level, and has presented multiple papers, including posters, as well as various other presentations in the national and international conferences. So I hand over to you, Tanmay. All the very best, and stay within time, and I'm sure you'll do well.
Good evening, respected judges. I'm going to present incidental wire markers positivity in cataract patients in tertiary eye care hospital. Cataract surgery, as we all know, is the most common operation performed worldwide. Last year, greater than 5.9 million cataract cases were operated in our country. Sharp instruments used during cataract extraction are potent source of hematological...
Sorry to interrupt, Dr. Srivastav. You might have to go into the presentation mode. Down below. No.
Doctor, can you press function F5?
Right there. Yes.
Yep. Thank you.
Go ahead.
Our aim was to find the prevalence of incidental wire markers positivity in the patients undergoing cataract surgery. It was a prospective hospital-based study carried out at our institute for a span of 30 months. It was approved by Institutional Ethical Committee and we strictly adhered to Declaration of Helsinki. All the patients who underwent cataract surgery were included in the study, and we excluded the pediatric patients. Pre-operatively, detailed ocular examination was done for all patients, and all blood parameters were investigated in NABS certified laboratory. Post-test counseling was given to all seropositive patients and were referred to ART center for further management. In order to elicit the risk factors, we gave a questionnaire to all seropositive patients, which included history of blood transfusion, receiving injections from unqualified local practitioners, history of any previous surgery, any tooth extraction, or having shaving done routinely from the barber. Total 8067 cataract patients were operated during the study period, out of which 7316 patients satisfied our inclusion criteria. Overall seroprevalence we observed was 2.9. Majority of patients were male, around 55%. Out of 7316 included patients, 212 seropositive patients were found in our study. Among the 212 seropositive patients, majority of them were HBsAg positive, followed by HIV positive in 0.8% and anti-HCV positive in 0.1%. Majority of patients were males in all the three groups. Majority of patients were between 41 to 60 years of age in all the three groups. We found 67 newly detected seropositive patients who denied any history of having any previous infection. And among them, HBsAg predominated in 35 patients. 27 were HIV positive, 3 were anti-HCV, 1 was both HIV and HBsAg positive, and 1 was HIV and HCV positive. We also find a positive correlation between the age of the HIV positive patients, and it was statistically significant. Similarly, we found a positive correlation between HBsAg positive patients and their age. It was also statistically significant, but the similar association was not found between anti-HCV positive patients and their age. We found a male association of male patients more having HIV patients, and this was statistically significant. Majority of patients were illiterate, around for half of them, and 29% of them were up to the matric level. Around 1/4 of them were graduated, and one patient was working in our ICU. He was a medical professional. The limitation of our study was that we did not include surgeries other than cataract, and pediatric patients were excluded. We relied on the history of patients and old medical records. To conclude, as we found in our study, significant number of viral markers positive patients who were diagnosed incidentally, we recommend that screening for viral markers should be made compulsory. It is helpful not only in protecting the healthcare providers, but also the other patients. Thank you. Thank you, sir.
Thank you, Dr. Tanmay. That was an excellent presentation. May I invite our esteemed judges, Dr. Biswas and Dr. Ajit Babu Maji, to lead the discussion on the case and the presentation. Over to you, Dr. Biswas.
You know that the transmission of viruses like HIV, HBs,
yes, sir,
or HCV are through the blood. And
yes,
unless you are wearing, having a needle bore, large bore needle injury, there
yes,
is a
sir,
chance of getting that infection is very, very, very remote.
Yes, sir.
So we really need not to do a routine testing of these viruses. For a, particularly in cataract surgery, where is a bloodless surgery almost.
Yes, sir.
So I don't think, and this percentage is so low. And then cataract surgery is done in HIV positive patients so many times. And only thing you have to take precautions, wearing a double glove,
universal
precautions,
precautions,
the instruments, so that you don't get sharp needle or instrument injury. I don't think there is a routine need for doing this testing.
So there are some studies like Temel et al. Said that HBsAg positive patients can transmit their infection through their tears and the aqueous fluid. And similarly, HIV and anti-HCV also, so some studies have been done. So that's why we try to, no doubt it is very less. The transmission rate is very less, being a bloodless surgery. And if we take all the precautions, then there is very less chances of infection.
Even the corneal transplant, if you done
Yes,
from HIV positive patients also, there is a very, very little risk.
Yes, sir. Unless there is unless we follow all the universal precautions, there are very less chances of infection.
Okay.
I agree, sir. Thank you, sir.
What are the positive rates in general population?
Pardon, sir?
The question
Positivity rate in general population, because you need to have a control group. You are screening only in patients who are reporting for cataract surgery.
Yes, sir. Yes, sir. Sir, the prevalence of HIV in normal Indian general population is 0.3%.
All three viruses.
Yes, sir. Of HIV is 0.3%. Of HBsAg is 3 to 4% in Indian population, and of anti-HCV is 0.019% to 4%. So according to an Indian study.
Since the incidence is so low,
yes, sir.
Do you recommend or do you justify this routine screening for all the patients?
Sir, I
Here
justify
you are screening all the 100 patients.
Yes, sir.
For catching one or less than one patient.
So since as if like in the winter season, we organize a lot of camps, especially in the peripheral areas. So we recommend that it should be made mandatory in order to protect the health personals and the other healthcare workers.
Or do you recommend in a specific group where the percentage of
high risk?
High?
So those who have an high risk behavior, but since in camp we could not elicit a detailed history, so sir, this should be made mandatory.
Yeah, either you come up with the guidelines for high risk.
Yes, sir. Yes, we want that guidelines.
Recommended. That is the choices you have.
So I have studied 1,000 patients of HIV positive patients. Only one patient was having a needle stick injury.
Yes,
that
sir.
particular patient was giving injection to is a healthcare worker, was giving injections, and then he got that. He was a nurse, actually male nurse. He got injury. Otherwise, there is not a single patient or single doctor who got HIV infection from the needle stick injury.
Yes, sir.
Dr. Tanmay,
yes, sir.
The first slide and the last slide, do you realize the enormous burden on the healthcare? You see, if you make a universal recommendation that universal should be done, Dr. Lahane is there because he has been into administration and, he is authority on advisor to government also. And the enormous burden that if you say routine screening, as Jyotirmay Biswas was rightly saying, because the percentage is so less. So I will ask Professor Lahane also to opine on this, because if we recommend, like last slide, and 5.9 million you said last year, that's sabka hi karna. Lahane sir?
I think, Lalitji, it is very true that such a burden, you know that the cataract burden is 1.4% in India.
Yes.
And in that, if we are doing, and you are also saying the Tanmaya in the camp, where we will send the all investigation, it is very difficult. So I think we should not say universal. Okay, per study, yes, you can do the study, no problem. But universally, it is not possible. And as the Biswas sir very rightly said, the percentage is very less. But you have done the study, yes, we should. I must say, Tanmay, congratulations for the study, but it is not for the universal, for the patients.
Thank you, sir.
So this is what I want to bring out between the first slide and last slide and take advantage of Lahane sir here.
Thank you, sir.
And he's done it in Banaras Hindu University, which is
that is admirable. That I agree.
So that is at least there you should do, because they will have a lot of high risk cases.
Yes, sir.
So in Prasad, previously we used to do all the screening. Then we found the percentage of positivity is very low, and then we stopped doing it.
Yeah.
And I think if we follow strict asepsis and what is used for one patient is never used for another, then we need not worry.
Correct.
All right. Thank you. So Dr. Parikshit, do we go to the next and the last speaker?
Yes, so we go perhaps the grand finale, the last and I don't know, we can't say the best because that's for the judges to decide. So I would request Dr. Upama Awasthi upload her slides. She is from Moradabad, Uttar Pradesh, and she is speaking on ORT and diabetic retinopathy. And we also have two very nationally, internationally eminent ophthalmologists, Dr. S. Natarajan and Dr. Jyotirmay Biswas, as our lead judges. And I would request Dr. Somashila to please introduce Dr. Upma. Dr. Somashila, ma'am.
I'm here, but I'm.
Dr. Amit is there.
Okay, I will do with
I am there.
Dr. Amit, can you go ahead?
No, I have it ready. Okay, fair enough, Amit. Go ahead.
Amit, go ahead.
So Dr. Upma Awasthi is practicing in Moradabad, and she is a vitreoretina consultant over there in CL Gupta Eye Institute. She has a great academic career. She has presentation in various forums at national level. She's the secretary for the WinRR WAS ethical team. She has received many awards. To name the WAS Research Award in 2018 for conducting the WinR sessions, which were very good sessions, the WinR sessions which were conducted by the WAS. So she has been awarded with many awards. She's a great retina surgeon. So over to you, Dr. Upma. All the best.
Thank you, sir, for such a kind words. Hello.
Yeah, we can hear you.
We can hear you.
Yeah, okay, sir. Good evening, everyone. I'm Dr. Upma Awasthi and going to present imaging biomarker for diabetic macular edema. And I would like to thank UPSOS and AIOC for giving me this opportunity, and I have nil financial disclosure. So coming to diabetic macular edema, out of 5 major variants, morphological variants, diffuse cystoid macular thickening is the most common variant. And as per the protocol U, this required continued anti-VEGF therapy. So if I talk about these two cases, which one should be treated? And one more query is, what are these structures? So this answer was given by Zufel et al. In 2009 as an outer retinal tubulation in chronic AMD patients. And later on, it was described in many of the conditions affecting macula. In DME, it was first reported by Halafi, and the incidence was 2.3%. So with this background, we have planned this study to find out the prevalence of ORT in diabetic retinopathy with or without DME. This was a retrospective study involving 81 eyes of 42 diabetic patients in a 1-year period, having no history of any anti-VEGF or intravitreal steroids for last 3 and 6 months respectively, and with clear OCT scans. At the result, we found that the prevalence that was reported with us was much higher as was reported in the literature prior. Even in 30.3% of the patient, we found ORT with DME, and in 4 eyes, we found ORT without DME. To our surprise, we have found no correlation of ORT with BCVA or CFT. These are the sequential OCT scans of a female who developed ORT later on during the follow-up. This is the male patient who had an ORT from the initial point of from the baseline, and it remained as such with an increase in the intensity and hyperreflectivity with time. And the same case happened with a 44-year-old male patient also. So coming to the discussion, how ORT develops? So the pathophysiology underlies the presence of long-standing intraretinal fluid, which causes disruption of the external limiting membrane and the photoreceptors, which later on this free edge of external limiting membrane start curling inwards, thus encircling the disrupted photoreceptors, and in this way forming initially open ORTs and then closed ORTs, as per described by Shell et al., who also said proved it by the histological report. So ORTs are basically outer retinal round to avoid structure with hyperreflective border, with no communication with inner cystic spaces, and with no leak on angiography. Despite having different morphological variants, their height is limited due to the outer nuclear layer location. And the course is usually stable, and sometimes they involute also. And they shows limited preservation of visual function that shows that there are some photoreceptors are still functional. So why I'm so much overemphasizing for the ORT in the scans? Because to avoid unnecessary interventions, And also, it is important to prognosticate our cases because these are present with in the chronic stage of the disease. And also, they are present in a very higher prevalence, which was not reported prior. But there are few limitations of our study that we have not done any dynamic viewing and it's a retrospective study. So to summarize, ORT, we should be looking for in every cases of DME to prevent unnecessary interventions and for the prognosis. Thank you.
Thank you, Dr. Upma, for sticking to the time. I would request Professor Jyotirmay Biswas to give his comments.
No comments from my side.
Professor Natarajan, sir.
Is he there? Natarajan.
Dr. Ajit Babu.
Yeah, Professor Ajit Babu, sir.
This is also there. Upma, you have said that you have not analyzed dynamic. And
Yes,
you
sir.
said in your this thing that OCT raster was seen.
Sir, dynamic viewing means I have not done the end-phase OCT actually to see the transfer sections also. And there no 3D viewing also because in newer OCTs or with especially the Cirrus ones, we can have the 3D structures also and with the spectralis. But with the iView system that is available with us, we have only done the raster scans, that 7 scans available with the iView, not all 15 scans with the OptoView. So this was little restriction from our side. So maybe we might have missed those few ORTs, or maybe in some cases we have thought of ORT in some cases because there are only 7 scans for through the fovea. So there are very much chances that we might have missed also with the iView thing that we have used.
So, are these scans are sufficient for you to come to any conclusion?
So actually, this was a pilot study. That's why, because we have just in one patient we found it. So retrospectively, we thought that we should be searching for this. But now we are planning for a prospective study, a well-planned study to have a proper protocol, proper inclusion/exclusion criteria, because they are just to avoid all limitations. Actually, all limitations cannot be avoided, but major of the limitations to be avoided, and better scans, better clear view, and better follow-up. So we will be, and our sample size is also less as compared. The 81 eyes are not very much enough seeing the diabetic population in India. So, and even the retina OPD is also very hectic. So even after that, we got only 81 clear scans. So that was the reason. It was just a pilot study, and we will be planning a prospective in a very near future. We are actually in the phase of planning.
You see, this outer retinal tubulations is not a new finding. It has been described more than 12 years ago. I think more than 12 years ago by so many authors. And it's not.
Yes, sir. In 1990, Karshio et al. Was the first one. That otherwise he has not named it, but he was the first one who described it. Yes,
no,
sir.
I'm not here to take any viva of yours when it was described. What I'm saying is, it's a old finding. It's not specific for any disease. It occurs more commonly in ARMD as well as DME. It's just a curiosity. They are degenerated photoreceptors which are in a tubular or a circular fashion. The basic aim is to identify them primarily because hypo surrounded by hypermembrane. This should not make anyone eager to jump in and start doing steroids or other treatment. There's just neurodegenerative phenomena. That's it. They are not signs of any fluid. They are not signs of any activity. So there's no point. They are just curiosities. Just don't be aggressive in treatment. That's it.
Yes, sir. Yes. Thank you, sir.
Thank you, Professor Lalit, sir. So, any more questions from any other judges, please?
But keep doing, Uma, keep working on it and identifying other disorders and then report. I agree. The percentage, what you said, you see initially like 1 or 2%. It's a reasonably prevalent kind of finding.
Yes, sir.
Great.
Thank you, sir.
Dr. Ajit Babu, sir.
Yeah, I think sufficient.
So I think we come to the end of this, and I again hand it over to our chief, our leader, Dr. Partha Viswas, to take it over.
Thank you very much, Parikshit and Feroz. Game abhi baki hai, so the marks are yet to come. So request all our judges to submit the marks, and in 10 minutes the results will be out. So in the meantime, we can ask our judges what they thought about the youngsters. Quick comments from all our judges, please.
Excellent presentation. Excellent presentation, but I am not the best person to judge it, but the presentation.
Can you mute yourself, please? Sir, you are possibly one of the best persons to judge all presentations, sir, with your citations and with your publications, which are enormous. Mayuri ma'am. Mayuri?
Any other judge Lakshmi, you want to speak?
Dr. Ajit?
Yes, sir.
But he will simultaneously go. We need to speak.
Can you hear me?
Yeah.
I've been doing oculoplasty now for the last 17 years, only plasty, but I enjoyed every presentation and I could follow, and I think they're very spirited and hearty congrats to Partha and team AIOS. Thank you. And all the presenters.
Thank you very much. Professor Lahane, sir.
See, Partha, first of all, thank you very much, because these youngsters, they are presenting very good. Secondly, they are studying. They are doing the research. And what we require, see, my post is Director of Medical Education and Research. The research was missing. So when I joined as a director, what I did first is I started the research. And so these students, they are doing very good research and reading also. So I really congratulate each and everyone. And it was it was very difficult to judge which presentation is best. But yes, it was 5 different things was given to us. So we gave the mark, but for everybody, 25 marks are there. Congratulations to each and every person. Thank you.
Thank you very much, sir. Sir, Dhami, sir.
Actually, I want to comment mainly out of 10, at least 5, 6 are outright very good papers. Rest of the 5, I would say they are immediately prepared and want to be pushed. That's why I don't want to name anyone or point out anything, but their enthusiasm is excellent and we need to appreciate that. That is very, very important, but at their stage, that is very much required, because a lot of future is there for them and they need to pursue this further. The 5, 6 papers, which are very excellent papers, they are really innovative. One of the marks was given for innovation. So they are very innovative. And the ideas which have come out of the box, actually, no one can think, and while listening also, we were thinking that why many of us not have done this before. That kind of a thinking, which is very good coming from the youngsters, is need to be appreciated.
Can you please mute the people who are not speaking, Sunil? From somewhere some noise is coming. Yeah.
But certainly good talent is coming up, Partha, and we need to encourage all of them.
Thank you very much, Dr. Jeet. Dr. Dhami, sir.
Dr. Partha, excellent presentations. And Shweta, you gave a very good innovation. Congratulations. Every paper was worth praising. Sumendra, you did wonderful. But I tell you, every paper gave us a new information, a new thought, and thinking is growing. And the new generation is giving us new thoughts and new ideas. Congratulations to all.
think each of the zones, Partha, had a different sort of a theme. This was more of, a mix. South zone had a different theme. One zone had only oculoplasty. One zone had only retina. So each of the zones is performing differently. The standard in each of the zones is also, I feel, different. So it's difficult to comment. And when the best from all the zones they get together, then I think we'll probably know, which is the best. But having said this, I still feel that we could get better. The presentations were good, whatever they were presented in each of the zones. But I think there's more talent, and it's okay to praise this. And like Dr. Ajit Babu said, that they were good. They're all good, but I think we can get better than this.
Yeah, thank you. AIOS is always there to improve upon the talent and to get fresh more talent and to inspire them, because we really did see some phenomenal innovations, real out of the box thinking in the other zones as well.
No, these things, Partha, should be tried in larger number of subjects. That was one thing which was lacking. If you have very few subjects and if you have very few people trying, and if the statistics and all are not that robust, or you can't, that was something which needs to be integrated into the whole.
Right. Yeah. Natarajan sir,
No,
you've been there.
No, I was observing, and I think as Namrata said, it still improve. And I think I believe in continuous improvement. But I think it's a great thing you've done by stimulating them to submit these sort of submissions, and everybody contributing something new. And I think it's great. And definitely there's a chance for everybody to think better. And I think you're creating a platform for them to think, recognized, and I think in each zone. So I think great.
Thank you. Thank you very much, sir. Anand, are you there? Anand Parsarthi? I think Anand has
muted. Yeah.
Okay. He's
Maipal sir.
So,
Maipal sir.
Yeah. So excellent presentations as always, and obviously every zone is doing better than the previous one, and I think again, Dr. Lakshmi, can you mute yourself, please, Dr. Lakshmi?
Sunil?
Yeah, thank you. So I think every zone is doing better than the other, and it is obviously showing the great talent that we have. And as was said right in the beginning, I think AIOS should do everything that is required to bring these to commercialization and at the international stage. So congratulations to everyone who participated, irrespective of whoever wins. Keep up the zest and keep up the stamina to go forward and bring your ideas into fruition and let them be utilized across the world. So great, Partha, again, and thank you very much to all the judges, because obviously it becomes a very, very difficult task time also. And I think this time also it will be that the separation between the people who will be going into the finals and those who do not reach the finals will be very minuscule. So for the judges, it obviously becomes a very difficult task. And I think we need to thank and very, very senior and eminent people who were judges like Dr. Jyotirmay, Dr. Lahane, etc. They were all great people who have devoted their life, Ajit Babu, Anand. So everybody, I think they have devoted their life to academics and teachings. And thank you everyone for being part of this wonderful series that the scientific committee is running.
Harit sir.
So, sir, Maipal sir.
Yeah.
So, how about disclosing?
Okay.
We have the 3 winners, and the 3 winners are there with Maipal sir, Dr. Lalit Verma, and Dr. Namrata. So, but we are not disclosing who is the top, because all 3 go up to the finals and the semi-finals and the finals. Therefore, we are not disclosing who is the top. Even Maipal sir doesn't know who is the top.
I even don't know whether they are in alphabetical order or not.
Random order, sir. Random order.
Actually,
Okay.
the secret is known only by a boss.
And the boss is always right. Okay, so anyway, I think without any further delay, because the heartbeats of people might be increasing, one of the winners that I'll wish to announce is Dr. Gunjan Saluja. Dr.
From
Gunjan, please.
Chhattisgarh.
From Chhattisgarh, yeah. Where is she? Can we have her short comments, Gunjan?
So Gunjan, where are you?
Yes, ma'am, I'm here.
Gunjan,
How do you feel?
like I said, was my thesis candidate.
You
look at Namrata, so proud.
Oh, I'm really proud.
she induced bias.
Ma'am has been. She's very hardworking, very sincere.
They all are from different states, ma'am, but unka
Yeah.
baki root ek hi hai.
No. It's
Yes,
good.
Gunjan.
So,
Don't
Gunjan,
worry.
how do you feel?
It's very good.
So,
Huh?
so first of all, I would like to thank my state ophthalmic society that they chose me to represent their state. And always there has been a good guidance which has been given to me, be it Namrata ma'am, any other professor in RP Center has been always a very good guide and a very good support. It's all because of them. So thank you, ma'am.
No,
Thank
it's
you.
all because of your hard work. You are
Great.
very hardworking.
Congratulations.
Thank you,
So,
sir.
Partha, next
Yes, sir.
to
Lalit sir, your comments and the winner from you.
See, first one or two lines. The beauty of this program is everyone learns. You see, this program was slightly different from the previous three in that the discussion was very nice and everybody participated in discussion. And I'm sure Dr. Lahane and Dhami and all the judges, Lakshmi, they participated with such great questions, and the candidates answered them all very, very nicely. And I'm sure judges must have been having a very tough time. The kind of questions also which were asked were also a testimony to the fact that you see, speaking about the quality of the program and the preparations. So congratulations to everybody. From my side, I think everybody is a winner, like Mahipal also said and Lahane sir also said. But since we have to announce and since we have to pick, and there was a lot of questioning by this DCR simulation, and you know whom I am pointing to. Shweta, you are one of the winners.
Congratulations, Dr. Shweta.
Congratulations.
You have to unmute, Shweta.
Shweta,
Yes,
your
yes,
comments,
sir.
your comments, please.
Sir, first of all, I would like to thank my mentors and teachers at PGI Chandigarh for my postgraduate training, and mentors at LV Prasad for my oculoplasty specific training. So without their guidance, I think it would not have been possible to me to innovate and get that great idea. Other than that, I would like to thank my state ophthalmological society for believing in me and sending me to this platform for representing their state, and it is I'm very grateful. Thank you so much for the opportunity. Thank you so much, AIOS, ARC, scientific committee members, for all the seniors and judges for taking out their time. Despite being so seniors, you are taking the time for the youngsters, for exploring, to showcase their whatever talent hidden inside, and it's a great platform for, I think, youngsters to what you have conducted. So I'm very grateful for you all. Thank you so much.
Thank you, Shweta. Thank you very much. And Namrata, lot of hearts are beating.
So I will say something, and the winner will know who the winner is. I traveled with him from Chhattisgarh, from Chitrakoot to Delhi. So it is Dr. Samrendra
Giving clues for the winner.
Samrendra Karkur for his talk on DALC with phaco-fragmentation, combining both anterior segment and posterior segment, and very challenging case and very difficult case to deal with. So congratulations, Samrendra.
Few words from you, Samrendra. Can you unmute? Yeah.
I'd like to thank all
Unmute
of you.
yourself, Doctor.
He is unmuted. Go ahead.
I'd like to thank all of you for giving us this platform, and we get an opportunity to present whatever we do day in and day out. to showcase and get awarded and rewarded for the same. I would like to thank my alma mater and mentors at PGI Chandigarh, where I did my MD and SRship, and the guidance and support of my current HOD, Professor Bhavna Sharma at AIIMS Bhopal. Because without her, I don't think I would have been here. So she encouraged me and asked me to participate in this. And thank you all the scientific committee members, and especially my MPSOS State Society and Divisional Society, who thought that I could participate. They nominated me for this presentation. Thank you so much, everybody.
Partho, one thing I would like to say common between all the winners has been the humbleness of all of them. All of them have been thankful to their mentors. All of them have been thankful to their alma maters. So that's a great, great sign of an achievers and success. So I like this three statements from all of them.
The maturity with which they are addressing is very, very hard.
That is what.
And all of them have either traveled with Namrata or worked with her.
No, sir, that has nothing.
Okay, great. Martha, great show.
Thank
you.
you.
Great job.
Congratulations, all winners. Congratulations.
Congratulations to everyone.
Any other of you, because all of you are winners. I mean, the top three just got to the semi-finals, but all of you have presented so well, are actually winners. And the podium is there for you, not only now, but beyond as well. So any of you would like to comment? Any comments from any of you? Karan.
So it was a wonderful opportunity and there were a lot of excellent presentations. And I loved absolutely being a part of this. And kudos to you and your entire team for, giving us young people the chance, to present in front of esteemed and legendary figures such as yourselves. Thank you so much.
Best thing to know, Partha, is Karan is out after 1 month from his house today. Karan is outside after 1 month. So after 1 month, he has come and he is into the scientific committee talent show. That's the best part.
Thank you, Karan. Nitin, Upama, anything, any quick comments you have?
It was a very. If I'm muted.
No, you're audible.
You're audible.
Yeah, because it's the message. It was quite a great comeback for me because I was at a maternity leave for last 8 months and it was extended due to the COVID. And at this platform, I think I was exposed to every specialty. Being a retina, I'm a retina person, but I was exposed to each and every specialty. So I'm now feeling like, yeah, I'm an ophthalmologist, not only a mother. So this was actually a very good platform for me to love to feel like an ophthalmologist.
Great. Neha? Who else is there?
Thank you, sir. I am Nitin, sir. Thank you, sir, for giving us this opportunity. Thank you, sir, for giving us this opportunity to present case among you all esteemed judges, and it's really a good feel to have such presentation in front of you all. Thank you, sir.
Neha is back.
It was a great opportunity to present and be stimulated to, in fact, even do much better than what we've been doing. So it was really nice to listen to all the innovations and ideas. Thank you for this opportunity.
Do be a part also of the semi-finals and the finals. And the next one is the North Zone. And let's see who is there from the North Zone. So, and then the semi-finals and the finals will be there. So do watch all of them. And the programs are really very invigorating. All of us feel so nice about it and really learn so many things that we do not know. We have lost.
Partha, before you sign off, I think on behalf of AIOS and everybody, I wish everybody a very, very happy Diwali and above all, stay safe and a safe Diwali.
Yes, thank you very much.
Happy Diwali
Thank
to
you, sir.
everyone.
Happy Diwali to all.
Thank
you to everybody. Thank you very much. Thank you, Partha.
Before we say thank you,
Bye-bye.
Diwali to all of you.
Bye, everybody.
Bye-bye.
Just 1 minute, Partha is to say something.
Parikshit, congratulations on assuming the post of President MOS, Parikshit.
Thank you, sir.
Parikshit.
So before we say thank you, and we have to acknowledge the great support of our AIOS team. That is our person who are working behind the screens. Pallavi Datta, our secretary for scientific committee, Mr. Kripal Rana, who is there in the headquarters, and Sunil Ji, who is there with us for our webinars, and for the flawless involvements of all these people. It's how the webinars take on. And Intus has been the biggest support. So thank you, Intus, and thank you, everybody, for being so supportive for the webinars that we are there. Thank you very much, sir, and happy Diwali to everyone.
Happy Diwali. Thank you.
Bye-bye.
Thank you, everybody. Thank you, Namrata. Thank you,
Thank you, sir.
Thank you, everyone, sir.
Thank you, Lalit.
Thank you, sir.